we commonly feel that whenever the topic of brain death or organ donation comes, there is a kind of unease among a lot of doctors. And I personally feel that being intensive care, that's one area which could be a major hindrance in taking up this much needed and noble activity to the next level. So, in collaboration with SNCC at medical hospitals, we thought, why not take this opportunity and try and address some of these issues, which would clarify a lot of doubts which we have, and at the same time give some insights to many of us, both from medical background as well as people from non-medical background, so that what is needed today, the idea and the act of organ donation can be taken up to the next level. Without wasting much time, I hand over the proceedings to Sahiti and Prodalika. Thank you very much.
Thank you, sir. You've not only initiated this event, but also infused it with meaning and momentum. We are deeply honored to welcome Srimati Lalita Raghuram ma'am, Country Director of Mohan Foundation, a global voice in organ donation advocacy. Ma'am has worked tirelessly to increase public awareness, train transplant coordinators, and support donor lives. A true pioneer and change maker. Now, ma'am will be speaking on organ donation importance, awareness, and unmet needs. Over to you, ma'am.
Happy morning, everyone, and thank you so much for inviting us, inviting me, Dr. Ghanshyam, and morning, Dr. Srikanth. I'll be speaking about the organ donation scenario in India. I've been associated with Mohan Foundation. Mohan Foundation for the past 24 years. I started the Hyderabad office in 2001, and since then have been seeing progress in different parts of the country. And I have also had the privilege of working with several critical care specialists, several neurologists and neurosurgeons across the country. So if organ donations have happened in this country, it is because of you. We work tirelessly in making organ donations happen, but as Dr. Ghanshyam said, there is an unease in talking about organ donation. There is also an unease in talking about brain death. So we look at what we have done so far in our country. So we passed the Center passed the Transplantation of Human Organs Act in the year 1994, and several amendments have been made. And I will not talk about the law because we have Dr. Gopal talking about the law itself. So we will move forward, and what has happened with the Act. With the Act, there are, now at least there is a recognition that the death can be declared in two ways, the cardiac and the circulatory death, and also the brain death. With the definition of brain death becoming, coming in vogue and also becoming popular in the medical scenario, a lot of critical care specialists have started declaring brain death, and that is how organ donation has been happening. Prior to declaration of brain death, the circulatory death, eye donation has been very popular. When I started in Eye Bank Association of India, we had only about 12,000 eyes collected all over the country in 1989. But today we have more than 60,000 corneas being donated. And Telangana and Tamil Nadu is leading in eye donations. And apart from that, of course, we have heart valves, bone and skin donations happening. In Osmania Hospital, we have a skin bank, so a lot of skin is also being donated. Of course, from the brain death, we see several organs and tissues being donated, like the solid organs of heart, liver, lungs, kidneys, and now hand transplant is also becoming popular, with Amrita Institute of Medical Science starting the program and several other centers now taking along. So what is the problem that we are dealing with? We have about 500,000 people who are waiting for different organs, suffering with end-stage organ failure. And every minute a name is added, and a lot of them, while waiting on the waiting list for different organs, die. And most importantly, those that are waiting for heart and lungs may die while on waiting list. At least for kidneys there is dialysis, and liver, if they don't get an organ within a year, they also die. So that is the scenario. So how are we doing internationally? Spain is leading with organ donation with 49.4 million per population donating organs. A small country like Spain is doing so well. India with 1.4 billion population has a 0.8 per million population donation. Not even 1, it is 0.8 per billion population. So this is what is the scenario. But the thing is, the potential is huge. 70% of our organ donors are road traffic accident victims, especially two-wheeler accident victims. And we find that there is a good potential. 93,000 organ donors can come out of these road traffic accidents itself. But what has happened? Look at the organ donations in our country. The deceased organ donations, was in 2013 was to 340, and last year approximately 1,250 organ donors. Out of which, if we have taken 5 organs, you imagine there are only about 6,000 and odd organs. So this is the scenario. On one hand, we have 5 lakh people. On the other hand, we have 1,250 organ donors. So which are the states that are doing well as far as organs donations are concerned? The ones that are green in the south are doing well. You can see that Tamil Nadu, Telangana, Maharashtra, Karnataka, Gujarat, the south and the west. These are the ones that are contributing to more than 70% of the organ donations in the country. Look at the north and the east. You don't have any organ donations happening. In West Bengal, they are in double digit now. They have just touched a double digit now. So this is the scenario because of which, most of the patients from across the country come down to south. On the brighter side is we are the 3rd transplanting country. How? We have done more than 18,000 transplants in our country. And where are they coming from? We are relying on living donors. Most of them are... There was a test done long time ago, more than 30 years ago. This was when I was trained. I got to read this paper. When you declare brain death, and in the same breath, if the doctors ask for organ donation, the success rate is only 30%. 3 out of 10 families say yes to organ donation. But if you pave the way for transplant coordinators, you declare brain death, give time for the family to grieve, and then the transplant coordinator comes and talks about organ donation, the success rate is 72%. 7 out of 10 families say yes to organ donation. So this is called decoupling. The act of declaring brain death and the act of asking for organs is decoupled. So in all our workshops, I keep talking about decoupling. And of course, there are some champions across the country, like Dr. Rahul Pandit talks about organ donation, Dr. Chinnadurai, Dr. Pradeep Rangappa, Dr. Kamath. So many of you have gone to the next step of asking for organ donation and have...
Thank you, ma'am, for your wisdom and unwavering commitment to this noble cause. Our next speaker is a highly respected critical care specialist and a guiding voice in transplant ethics and clinical protocols, Dr. P.B.N. Gopal sir, who currently serves as a Director of Critical Care at Citizen Specialty Hospital. With his expertise and experience in intensive care leadership, protocol development, and donor management, Sir brings both clinical authority and deeply ethics lens to organ donation practices. Sir will speak on the subject that governs and shapes our practice, the legal framework for brain death certification and organ donation in India. We welcome you, sir.
morning, everyone. Thank you, Lalita, for that very, very inspiring and nostalgic talk, taking us back by a couple of decades of the little efforts people like me put in this field. The reason probably the organizing committee led by Dr. Ghanshyam chose me to talk on this particular topic is my background. I was a liver transplant analyst for considerable time. I was a volunteer of Mohan Foundation along with Lalita Garu, evangelizing the brain death and organ donation concepts. And then I metamorphosized into total intensive care consultant, managing various intensive care units across the country. Now, what Ghanshyam has done today is that converted me to a legal opinion specialist. I have been speaking about the clinical side of brain death all my life, of course following the law. So I had to look deeper into it. So I also thought that speaking about brain death alone is not going to take us anywhere. We have to look at the evolution of death. However much all of us accept that death is definite and ultimate finality, it doesn't seem so. Death seems to be dynamic. The way human race, before they got educated and after they got educated, and medical field became an accepted specialty, the way they look at death seems to be changing. So we'll go through that in the first few portions of the slide. But before I do that, I have some disclosures to make. What we are about to define is the current status of legal death. It's not biological death. As doctors, we are empowered to declare a patient dead. This is legal death under the law of the land that you work in. Medical practices, including declaration of death, are subject to law of the land. In India, they are subject to the state that you live in. As we stand here today, in the state of Telangana, we are subject to law passed by Telangana government. And you have to abide by it. And circulatory death is declared by any registered medical practitioner. Whereas brain death is declared by only those medical practitioners which are allowed to do so by the medical appropriate authority, which in this state is Director of Medical Education. Then, as everybody knows, law is subject matter to interpretation. Laws don't give you a clear yes and no. You have to interpret the law and apply it to your circumstances. So when we come to the legal section of this talk, what I am telling you, what I am about to tell you is my interpretation of that law. You may interpret it differently. And some opinion I am going to express are my own interpretations. Death and diagnosis in the past, basically it was circulatory or cardiac death. Upon the suspicion that someone is not alive anymore, either a layperson or a doctor would approach the person, either you do CPR or not do CPR, patient may not survive, and you look at three components. There is no pulse or heart in the modern times with a stethoscope or with an echocardiogram. Patient is not breathing and patient is not conscious. Note that even in this modality of the death, not conscious, not breathing is also there. Not only the heart. These two components are common to brain death and cardiac death. And you declare the person dead. That was true in our country till 1994. This is the only way of declaring death, in fact. Before the medical profession evolved as a licentiated profession to declare death, the diagnosis of death was very dubious. Many people were buried alive. Some famous personalities, Alexander the Great, was supposed to be buried alive. So once medical profession developed and got the legal sanction of declaring someone as alive when one is born or someone as dead when someone is circulated dead until 1994 in this country, they were the licensed doctors who were empowered to do so. But if you go to legal side of the definition of the death, the definition of death hinges on these three basic characters of an organism, which is respiration, circulation and brain function. Again you see here that respiration and brain function come in, and when brain fails, we all know that the patient becomes unconscious. So the functional failure of any one of these three systems may upset the rest of the two systems and make the organism dead. This is the fundamental basis of saying that someone is alive or someone is dead. In the legal dictionary, Black's dictionary that a lot of people follow, it is defined as the cessation of life, the ceasing to exist, defined by the physician as total stoppage of circulation, note it, of the blood, and excitation of animal and vital function consequent to stoppage of respiration, pulsation, etc. Even in this circulatory death, this is before 1994 and before brain death loss was passed, even in this, respiration is mentioned. So what happened to the evolution of the present status of the death? What we have talked in the last 5 or 6 slides is the pre-brain death era. But how did the concept of brain death arise? Fundamentally, Andreas Vesalius, a Spanish exhibitionist and a man who used to take pleasure and pride by dissecting dead bodies and displaying his organs to various audience. Once he dissected a dead body and the heart was beating, the king of Spain admonished this guy and expelled him from Spain. He ran away to Austria and died there. That is the first incident of someone seeing a heart beating in a corpse. Then came Sir Horsley. He found out, he is the neurosurgeon in Queen Square Hospital in London, which is the most famous neuro hospital, and he was the first neurosurgeon there. He said that if artificial respiration is continued, it will be impossible to kill an animal by increasing intracranial pressure, indirectly denoting that an irreversible increase in intracranial pressure would not by itself kill the patient if he is continuing to be ventilated, whereby he means the heart is still beating. He still did not utter the word brain death. Then came 1959, a very important year, not least because I was born in that year. But these two people, Mollet and Gowland, have observed in polio patients that they went into an irreversible coma. They were done tracheostomies and put on either manual ventilation or primitive ventilation. Their hearts continued to beat, but they never woke up. They called it coma dépassé, and they gave several features, in which the most important feature is there is no spontaneous breathing and there are no neurological reflexes. Then came Henry Boucher, a very, very important figure in American medical history and literature. He found out that after reading all this, he had a very seminal opinion that we should first abandon the ancient sign of death, the cessation of heartbeat. Because till then, no heartbeat is equal to death. And there is no other way death can be declared. And individuals die, but their cells continue to mobilize. This is what I said in my first slide. What we are declaring, the body continues to function, or else how do we explain the organs which are transplanted living for decades in others' bodies? Because the circulation is maintained. So these two statements from Boucher, Henry Boucher, laid foundation to one, brain death, and two, organ donation. This was taken cognizance by Harvard committee, and they put in Harvard criteria of brain death, among which again no movement or breathing, apnea, the test which we do technically now, found cornerstone. This was taken up by President Commission of USA. Individual who has sustained either irreversible cessation of circulatory or respiratory functions, irreversible cessation of functions of the entire brain, including the brainstem, is dead. This is a uniform death. They fundamentally changed in their constitution the definition of death, including both brain death and circulatory death. This is yet to be done in India. This is what Mrs. Lalita was elucidating. Several representations have been made in both state and central government to modify this, and it is not yet done. And this lack of uniform definition of death in the Constitution of India is the reason which is leading to a lot of confusion, lot of questions, self-doubts, both public and professional, and lack of organ donation. This is still work in progress, work in pending. So the evolution of brain death, I won't bore you with all that happened, but please note the last two points. After all the events that we saw in the previous slides happened in 1994-95, brain death defined act was passed by central government. I will tell you the story in the next slide. And it was automatically adopted by states. But the story didn't stop there. The story didn't stop there. It went further. WHO took up the issue, and that is the subject matter for further discussions, probably in neuro congresses and critical care congresses, whereby WHO is trying to unify definition of death for both brain death and cardiac death, and saying that everything is ultimately brain death, because if you can't do CPR or won't do CPR, the patient's brain would die anyway by the time you declare a cardiac death. But that is yet to happen. That is some work in progress. Now, what happened in 1994 is actually very interesting. We all know that P.V. Narasimha Garu is a pioneer Prime Minister of India who turned our economy. But he turned our brain death and organ transplantation issues also. He was instrumental in getting this law passed. The story goes that Dr. Venugopal, Professor Venugopal, head of the Department of Cardiac Surgery, was itching to do heart transplant and asked the center to pass brain death law. And it was not moving forward. He sought the help of Shamiran Nandi, who was the head of the Department of Surgical Gastroenterology and a great thinker. He was, for people in that generation, he was a continuous talk show guest in various television shows. By the way, he is brother-in-law of Pranav Roy. Pranav Roy used to invite him for several talks. So he asked for the help of Shamiran Nandi, and Shamiran Nandi wrote the draft of this act, Transplant of Human Transplantation Act. And Venugopal sir, being a personal friend of P.V. Narasimha Rao, approached P.V. Narasimha Rao to pass the law, and he agreed, and the law was passed in quick succession, and states picked it up as it is that year or next year. Andhra Pradesh was the United States at that time, United Telugu State. They picked up the law in 1995. In 2014, when Telangana was declared independent state, they sumo moto completely adopted that law. If you go to Jeevandan's website today and ask for brain death law, even today Andhra Pradesh law is reflecting there, Andhra Pradesh organ donation law. So what are the aims of TOTA? This is extremely important, because this definition of death is given in Transplantation of Human Organs Act, not in the Act of Birth and Death. Okay, the first aim of the court is to recognize brainstem death and allow organ donation from brain dead donors. This sentence is causing a lot of problem of declaring death in a brain dead patient who does not want to give organs. This particular clause. Of course, it is a subject matter to interpretation. I myself, when patient did not want to pay income, did not want to donate organs, I declared dead and wrote death certificate for several patients over the last decade and a half. The second one is regulation of removal, storage, implantation of human organs. This applies to life related also. Prevention of commercial dealings in organs. We are not going into those two topics today. So, TOTA definition of the death, if you look at very keenly on this important definition, the Act defines a deceased person as one in whom permanent disappearance of all evidence of life has occurred by reasons of brain stem death or cardiopulmonary at any time after life birth. This looks like a combined definition of law, death. But the problem is, this is there in the Transplantation Act. It is not there in the Fundamental Birth and Death Registration Act. So many people, many luminaries, many politicians, many policymakers and doctors are objecting to declaring a patient dead, even if brain death is established technically, if the patient is refusing to give organs. That is throwing a lot of dilemma into management of these patients for the intensive care, neurosurgical, neurological branches. Then brain stem death, that is second component. India accepted that brain stem death is brain death. There are very few countries or very few states in the United States of America who want whole brain death. That is decreasing by day anyway. So as we stand here today, for us, because we follow the law of the land, brain stem death is brain death. Further definition, the stage, brainstem death is the stage at which all functions of the brain have permanently and irreversibly ceased. Deceased person is a person in whom permanent disappearance of evidence of life occurs by reason of brainstem death or in cardiopulmonary sense at any time after life birth takes place. We have seen this. Near relative, this is important because these are the people who can consent for taking organs and accept brain death. Spouse, son, daughter, father, mother, brother, sister, grandparents or grandchildren. The increase in the pool of consentable people has increased over the years by several amendments. Interestingly, ever since 1994 brain death law came in, TOTA came in, some amendments are being made and are being made, but none of them belong to brain death itself. They all belong to transplantation. In the fundamental definition of brain death, we are still standing where we stood 26 years ago, 30 years ago. There has been no change there, or the positioning of this definition has not been moved from TOTA to Fundamental Births and Registration Act. It still sits in the Transplantation of Human Organs Act. So these are brain death criteria. I am not going into this. You are all either doctors or transplant coordinators, and there is a separate lecture about how to declare brain death. But more important is, these are the steps. Some of these slides are kindly given to me by Dr. Rahul Pandit. He has given a wonderful lecture in the NOTA symposium, cross-country symposium a couple of weeks ago. These are the 3 steps in which you go. Establish if there is an underlying potential cause. This is the first pitfall. Look at the potential cause and no obvious contraindications. Step 2, look for confounders. Make sure there are no confounders. Again, someone else will address this. Step 3, identify brain death by complete neurological examination. Who does it? This is a legal issue. Testing can be done after 4 hours of no recordable brainstem death bedside by nurses, doctors, provided 3 conditions are met. Testing is done by 2 doctors at an interval of 6 hours apart, who can be neurologists, intensivists, neurosurgeons. This is very important because the appropriate authority has recognized doctors beyond neurosurgical science to do brainstem testing and declare brain death. Certification is different. We come to that. 2 more persons above the process and sign off the final document. There are prerequisite documents. Who certifies the brain death? The first one, the declaration. This is certification. Some hospitals have a brain death committee. If there is no committee, it can be constituted at that point of time. The brain death certification has to be done in a different form by medical superintendent, who is in charge of the hospital, independent RMP, 5 years of PG experience, neurologist, neurosurgeon approved by the appropriate authority, registered medical practitioner treating the patients. So these regulations in Andhra Pradesh, which was followed by Telangana, have been handed over to a governmental authority called Jeevandan. Jeevandan regulates the whole process of organ donation. As I read into the Jeevandan's preamble and their content, they don't dictate to declare brain death. They don't have a role to play there. But they have a role to play what happens to the organ if patient family consents to give organs. Jeevandan has given several forms. First thing is, a hospital in which transplantation is done has to have a Jeevandan license, which is loosely called a certificate, which is loosely called a license, transplant license. This license is specific for organs, specific for life related, specific for cadaveric. Some big hospitals have that, across the board have got all the licenses, and this has to be renewed. Rigorous inspections are done and track records are kept in view. These are the various certificates for brainstem death testing and declaration. These forms are provided on the website and they have to be followed. Brainstem death certificate from appropriate authority for cadaveric transplant. This is certification. The 4 nominated people have to do this. Organ donation consent form, there is a double consenting. There is 2 different forms which need to be consented. This is all the domain of the transplant coordinators. Each hospital mandatorily should have a transplant coordinator if they want to be a transplant center. And it is their responsibility to see that each one of these forms is judiciously filled and duly signed. Police have to be informed, especially if it's an MLC. Forensic doctor has to be informed. Forensic doctor will consider the retrieval process of the organs as postmortem and declare that organs can be taken if there is no foul play. And then organ retrieval authorization from the patient family also has to be taken for specific organs. Now proposed algorithm for this is, this is very small. In summary, I can tell you, the thing is, you have to first look for signs of brain death, brainstem death. If they are not there, you have to review the process. Then you have to look for confounders and mimics of brain death. If they are not there, you can proceed for brain death testing. If brain death testing is done and patient meets the criteria, the same has to be repeated 6 hours later. Obviously, if they are not met, you have to abort them. I am not talking about ancillary data, someone else will talk about it, because if the clinical brainstem death testing fails, or there are confounders, or there are limitations to do this testing, then we go to the ancillary tests. I think one of the colleagues will take up that issue. Now the problem comes in state of Telangana that technically and medically you have established brainstem death and declared the patient brain dead. Can you give the brain certificate or not? Kerala is saying that you can. Telangana state has not made it clear and left it to your courage, your imagination and your decision and your coordination with the family. Now these scenarios have been addressed by some papers in India itself, some research papers. This is a wonderful paper coming from multiple institutions. The legal void outside brain death in India, the legislative need for DNR in brain death. Various doctors and some lawyers from PJ Chandigarh, NIMHANS Bangalore, Indian Institute of Law, Indian Institute of Law Delhi, and some other hospitals. There is an Apollo think tank for these things. They collaborated, formulated a model case where patient becomes brain dead but family refuses to give organs. What could be the scenarios, what could be the medico-legal conundrums in such case? They circulated it and they followed a meta-analysis Delphi method, sat down and came up with several questions and answers, possible answers. These are all opinions subject to interpretation. One thing that is outstanding in this paper is that they said if patient becomes brain dead, he is declared according to the law of the land and patient's family accept to donate organs. Before you declare the patient dead, take a DNR declaration from the patient family to avoid any medical legal hassle to a given institution in future, which none of us are doing. I don't know how many senior luminaries here are doing that. We have never done that. We have done scores of organ donations in our various hospitals. We have never done this. When Dr. Rahul is speaking, he can give his opinion about it. Even Lalita can give her opinion about it. Now the conundrums rising out of such situations in our medical practice and in this particular research paper. There are some minor papers also, case reports also. First thing is, I'll go question by question. This is my last but one slide. What if family does not want, okay, we'll go to next slide, the answers also there. What if family does not want you to perform brain stem death tests? Some families said don't perform. In my opinion, and opinion of many of my colleagues, we don't need consent of the family to do brain stem death tests. I had arguments about this with some of my non-critical care colleagues. I went ahead and performed the test, even if family said no. Because it's a clinical test, I'm only examining the patient, I'm not doing any intervention, neither am I going to close the case by myself without further consultation. So first question is, brain test as a clinical test, it does not need anybody's consent. Second conundrum, second doubt, brain death is confirmed and family consents for organ donation. What next? Follow the law of the land. As we stand here on Telangana's land, follow Jibandhan, organ retrieval followed by ventilator disconnection. Hand over the case to your organ transplant coordinator, he will do the rest. The decoupling that Lalita was talking about. Now the question here arises as a corollary to this particular question is, can you just disconnect the ventilator at the end of retrieval and declare death? I have done that several times, starting from 2003 to today. I have done that several times because that is my interpretation. If I don't do that, if I declare death after organs are taken, that technically means I have taken organs from a living patient, which is a crime. So on that basis, I declare death even before organs are taken, which is second death crime. That many states are supporting, many international papers are supporting. Family access brain death, no consent and asked to discontinue ventilation. What do? Counsel for non-escalation of treatment, take a DNR, take a do not resuscitate, again according to the law of the land, which is very dynamic. EOL and DNR are boiling pots. Put your hand in that and it will be burnt. So please understand that, follow the law, it is evolving. There is another lecture tomorrow in the main congress about EOL, panel discussion in which we can discuss this further. So if patient is brain dead, they are accepting but no consent, you better go down the EOL DNR pathway. But that needs a lot of counseling. Family accepts brain death but wants to continue till the heart stops. It's a very common scenario. They neither want to give organs. They say, okay, he is dead, you are talking about some land, all that, but for us he is alive because heart is beating, our religion, our family, our mother-in-law, they don't accept it. You continue. What do? Decision is driven by cultural situation where you live, that family, the religion, and of course the temperaments at that point of time of the family's temperaments. Be very cautious. You have to patiently continue to counsel. Perhaps you can take DNR no escalation orders at this point of time. The last question, what is the time of death is confirmed brain death and with or without donation? In my opinion, it is second brain death test positive time. Though again there is a small controversy there. The second test is only confirmatory test. It's not a diagnostic test. You made the diagnosis 6 hours ago. You are confirming 6 hours of the death, that patient is still dead. Any case, to avoid legal consequences and not to increase pressure on the patient family and to expedite retrieval process, we better declare the brain death time, second test brain death time as brain death time. So these are the thoughts that came to my mind, but there are changes that need to be done. Unless we make these changes, the people involved in this particular activity, trade or non-trade activity, are not at peace and not safe. First thing is, there has to be constitutional changes for 2 modes of death. Universal determination of death has to be enacted in the law of birth and death of Indian Constitution. Second, term death need to be used for both kinds of death. That is going to happen maybe a decade later, depending upon what the committee which I talked about under WHO is working. Clarity to medical professionals that death can be declared due to brain death and even when organ donation is not contemplated. This is my opinion. I leave it to your judgment. Government certification workshops are entitled doctors to declare brain death and periodic rectification have to be mandatory. They have given the power of declaring death to a particular close group of neurologists, neurosurgeons, intensivists and some anesthesiologists. But they are not being trained this. When we were medical students, we didn't even know that this term existed. And we have never been given a training. Like, for example, if you want to prescribe HIV medicines, you have to undergo some kind of HIV training. Here is not the one. Of course, organizations like Mohan Foundation are doing this kind of job, but it's voluntary. It's not mandatory. In my opinion, it should be mandatory to get the power of declaration in your hand. It has to be mandatory training. And lastly, changes in medical education curriculum at a basic level, at a medical school MBBS level have to be done to make them very aware of this. This has got profound implications on the future of these doctors and their influence on the events in their particular institutions. And lastly, lives of hundreds of waiting recipients, hundreds of thousands of waiting recipients. I got this opportunity to put a few of my thoughts and learn a bit about
Topic today, brain death, definition, pathophysiology and declaration is a critical foundation for our entire day's dialogue. We welcome you, sir.
Good morning, everyone. I'm Dr. Ranjit, consultant neurophysician at Medicor Hospitals. I would like to thank Ghanshyam sir for giving me this opportunity, and I would like to thank Neurocritical Care Association for affiliating with us and helping us in organizing this conference. So I will be talking about brain death definition, pathophysiology, and declaration. So I will be talking about the sequence of steps which needs to be followed to avoid nuisances in declaring brain death. So death is declared by two criteria. One is cardiopulmonary criteria, and the second one is declaration of death by neurological criteria. So brain death or death by neurological criteria is an accepted criteria in most parts of the world, and it constitutes about 20% of deaths in hospital and overall worldwide. And in 1968, a multidisciplinary committee from Harvard Medical School first introduced the standards for brain death. Later on, many amendments were made and many standards were brought by different organizations like the American Academy of Neurology, Society of Critical Care, and pediatric associations. So all of these have helped in setting up few standards which help in preventing nuisances in declaring brain death. So there are three definitions which are used in declaring brain death. Dr. Gopal sir has actually told regarding this brainstem death and brain death. I will be covering them in detail. So one brain death is whole brain formulation. So first mode is whole brain formulation, which is accepted in the United States and followed in most of the parts of United States, which means catastrophic injury to all parts of the brain, which includes cerebral hemispheres, diencephalon, that is thalamus, and all parts of brainstem and cerebellum. That means all the parts of the brain should be damaged to declare a patient to be having whole brain death. In this view, completion, this requires establishment of damage to all the organs of the brain. So next one is brainstem death formulation. So brainstem death formulation is accepted in UK and in India. So it requires only establishment of loss of brainstem function clinically, and even radiologically the loss of brainstem, the damage to brainstem is required for declaring a patient death. But in most of the scenarios, brainstem death succeeds the cortical death, because there will be raised ICP and there will be herniation into the infratentorial region, which will be causing brainstem death. But in few scenarios like basilar occlusions, which may be causing pontine midbrain and medullary infarctions, and brainstem hemorrhages, and in conditions like brainstem encephalitis, these are the conditions where brainstem death can occur isolatedly without the loss of cortical functions. I mean without the damage to the cortex. So this happens in less than 2% of cases. And in India, usually brainstem death is followed a criteria. And the third and very less accepted criteria is loss of higher cortical functions, that is damage to only cortex, which is dependent upon the concept that the cortex is required for the cognitive function of a person, and if the cortex is damaged, even if the brainstem in intact, patient will be in vegetative state, but this is not accepted in many parts of the world. So these are the three ways of defining brain death, and in India we follow the brainstem death formulation. So coming to pathophysiology of brain death, so elevated ICP leads to increase in mean arterial pressure. So when the elevated ICP goes beyond the mean arterial pressure, there will be only systolic flow into the brain and diastolic flow may not be there into the brain. And when the elevated ICP goes further beyond the systolic blood pressure also, there will be no flow into the brain, and which may cause herniation of tissue into the herniation of the cortical tissue into the brainstem. So in the brainstem, the damage happens in a rostrocaudal fashion. Rostrocaudal fashion means the first part to get damaged will be midbrain, next comes pons, and next will be the medulla. So when the damage happens to midbrain, there will be significant vagal stimulus, which will cause decreased blood pressure, bradycardia, and decreased heart rates and decreased cardiac output. And next damage will happen to pons. When the damage happen to pons, there will be superimposed sympathetic stimulus on the pre-existing vagal tone, which will give rise to Cushing's reflex. So in Cushing's reflex, because the pre-existing vagal tone, there will be bradycardia. Because of the sympathetic stimulation, there will be hypertension. So this is the reason for which usually sympathetic stimulus should cause tachycardia and hypertension. But because of the pre-existing bradycardia, vagal tone, there will be bradycardia and there will be increased blood pressure. And next structure of brainstem to get damaged after the pons is medulla oblongata. So medulla oblongata has this vagal cardiomotor nucleus which becomes ischemic and completely the vagal tone is lost. And there will be unopposed sympathetic stimulation. Up to the pontine stage, there will be both parasympathetic and sympathetic stimulation. When the ischemia progresses to the medulla oblongata, there will be only unopposed sympathetic stimulation, which will lead to a sympathetic storm. So this sympathetic storm may lead to unopposed arterial hypertension, tachyarrhythmias, myocardial dysfunction, stress cardiomyopathy, and neurogenic pulmonary edema. So, and the herniation triggers to inflammatory cascade that can affect the cardiopulmonary functions. So, this is the pathophysiology of brain death. And as Sir covered Transplant of Human Organs Act in 1994, who can declare brain death? So, brain death evaluation according to our law can be done by 4 people. One medical administrator in charge of the hospital, the people who are involved in declaring brain death. So, examination is done by usually neurologists and neurophysicians, and I will be telling who can do the examination. Medical administrator in charge of the hospital is involved in this team. Authorized specialist by hospital is involved, and authorized neurologist or neurosurgeon and medical officer who is treating the person. And according to the amendment made in 2011, it also allows physicians and surgeons, if the neurologists or neurosurgeons are not available, and also anesthetists and intensivists can examine a patient for brain death if a neurologist or neurosurgeon is not available in that hospital. So this is the amendment made in 2011. So these are the laws covered by Sir. So first, coming to prerequisites for a brain death by neurological criteria. Performance of evaluation of brain death should only be considered if the patient is comatose and having absent brainstem reflexes and is not breathing spontaneously, and etiology is known and catastrophic and cause irreversible brain damage. So etiologies that can lead to brain death and cause irreversible brain damage are hypoxic ischemic encephalopathy, patients who underwent cardiopulmonary resuscitation or who sustained HIE because of any reason, or patients who had large hemorrhagic strokes or large ischemic strokes with midline shifts, or traumatic brain injury, bacterial meningitis, viral meningoencephalitis, or patients who had acute obstructive hydrocephalus. And the conditions which may mimic brain death are, these conditions are very important and should be kept in mind when we are examining the brain death patient. Fulminant Gulielmi syndrome, which may sometimes even have brainstem encephalitis, botulism, and high cervical cord injuries, snake bites, rabies, and severe hypophosphatemia and severe metabolic derangements. So these are the conditions which may mimic brain death. So before proceeding, we must establish whether the injury is irreversible or not. So establishing irreversibility is very important before proceeding to any examination of brain death, which can be done by repeated clinical examinations and also by, and very importantly, by neuroimaging. By checking the intracranial hypertension, whether the ICP is more than mean arterial pressure. These are the indicators which will, the brain imaging and checking the ICP, which may be more than MAP in cases of irreversible brain injury. So these things should be established before proceeding further. And confounding factors should always be kept in mind, like hypotension in adults. Before proceeding for brain death examinations, blood pressure should be more than or equal to 100, and in or mean arterial pressure should be more than 60. And in pediatric population, it should not be less than 2 standard deviations of the that particular age. Hypoglycemia should not be there. Hypothermia in adults, the temperature should not be less than 36 degrees centigrade. And in pediatric population, temperature should not be less than 35 degrees centigrade. And severe derangements of electrolytes and pH should be checked, and if possible, they should be corrected. So there are no particular definitions of the pH or sodium levels or any metabolic derangements, but all the criteria, according to AAN or World Brain Death Organization criteria, they tell that severe derangement should be corrected. Probably one sodium more than 150, few articles say that sodium more than 150, or few articles say that sodium more than 160 needs to be corrected. pH less than 7.3 needs to be corrected. So always intoxication should be excluded, and the drugs that may cause CNS suppression should be checked. For example, blood alcohol level should be less than 80, and wait for at least 5 half-lives for the drug to get excluded from the body. And we must take into consideration the hepatic and renal impairments, and we may have to give more time before the drug to get metabolized. And we must exclude the pharmacological paralysis either by nerve conduction studies like that is a train of fora, or by clinically by assessing the deep tendon reflexes. And the laboratory parameters, like as I told, the severe metabolic derangement needs to be corrected. And these are the drugs that may cause CNS depression and may give false positive brain death. So when any of these drugs are in circulation, or when we are giving any of these drugs, definitely we may have to wait for them to get metabolized in the body or washed out from the body, and we may have to give, we should give definitely enough time and at least 5 half-lives for these drugs to get metabolized, to get washed off from the body. So now coming to clinical examination of a brain death or a death by neurological criteria, this is the most important one which I want to stress. Once the prerequisites of the brain death are met, a clinical examination is performed to assess the coma and the absence of a motor response of face and extremities, and brainstem areflexia should also be established. So, definition of a patient being comatose is absent motor response on face or extremities to painful stimulus, that is tactile stimulus, painful stimulus, auditory and visual stimulus. Patient should not have any response to any of these stimuli, and no cerebrally mediated movements following application of painful tactile stimulus to face and 2 extremities should be checked. If the extremities are not there, on 2 locations on one extremity can be checked. So when we are clinically examining a patient, although patient might be having although patient might not be having any of the cortically mediated movements, or patient might not be having any of the brainstem reflexes, they may be having few motor movements which are actually mediated by spinal cord. So these movements are segmental myopia. Can you play the first video? So this is how a normal corneal reflex is seen. So pons is intact, there will be fixation of cornea, there will be fixation of eye, and even when the head is rotated, our eye will be fixed and it will not be rotated along with the eye. That is called as normal dorsal, and the dorsal is lost in brainstem reflexes. Next one, next video. Yeah. So if you see in this video, when the head is rotated, the cornea is rotated and the eyeball is rotated. So this is loss of dorsal reflex, which again indicates pontine dysfunction. So this is called as oculocephalic reflex or dorsal reflex. Next slide. So next important part in examination is oculovestibular reflex, which is actually more sensitive and specific when compared to the doll's eye. It examines the same pathway, but sometimes doll's eye we may not be able to perform doll's eye, especially in cases of high cervical cord injuries. We may not be able to rotate patients' head sideways. So in these cases, oculovestibular reflex can be checked. So the prerequisites for checking oculovestibular reflex is head end should be elevated for by 30 degrees and 50 ml of by 30 degrees, and tympanic membrane rupture should not be there for those patients. And a 50 to 60 ml of cold water should be injected with the help of a small tube into the ear of the patient, and the eye movement should be examined for 1 minute. So in the first video we can see a normal oculovestibular reflex. So cold water is injected, and after the cold water is injected, slowly the eye starts and there is a nystagmus. So it can be remembered by the famous mnemonics which neurologists remember. Cold water will have opposite side nystagmus and warm water will have the same side nystagmus, cows. So we are injecting the cold water. If the brainstem is intact and the brain is intact, a slow phase will be there towards the injected side, and a fast phase of nystagmus will be there towards the opposite side. So that is normal. And in cases of brainstem dysfunction, patient may have only tonic deviation of eyes towards the right side, and there will be no correction saccade towards the opposite side. And in brain death, there will be no movement of eyeballs after injecting cold water. So after injecting cold water, at least we must wait for 1 minute to assess for these eye movements, and after 5 minutes we must do on the opposite side. After 5 minutes we must do on the opposite side so that the equilibrium will be established. Next slide. So next is gag reflex, cough reflex. Gag reflex is stimulating the posterior pharyngeal wall, and cough reflex is by stimulating the tracheobronchial tree. Both these reflexes helps in establishing the intactness of medulla oblongata. And in pediatric population, it is very important to do sucking reflex and the rooting reflex. So this is sucking reflex. A gloved finger should be kept in the mouth of the baby, and there will be spontaneous suction. And rooting reflex is if we tap on the cheek of the baby will turn towards the side of the tap and will try to latch the finger. That is the rooting reflex. So these are the brainstem reflexes which should be checked in pediatric population. And minimum number of clinical examination for brain death is 1 in from the baseline. So usual CO2 rise in a brain death patient is 3 mmHg to 5 mmHg per minute. But the evaluation is done after usually 8 minutes, and sometimes in doubt we may wait up to 15 minutes also. And number of apnea tests is 2 minutes, 2 in adults and 2 in pediatric population also, which is done, and the time interval between the first test and second test is 6 hours. So before checking for a second apnea test, all the clinical examination, all the brainstem reflexes needs to be checked again. So according to Indian law, in US they usually do only once apnea test. Reasons to abort the testing are spontaneous respiration witnessed, or systolic hypotension, systolic blood pressure going below 100 mmHg, or mean arterial pressure dropping below 60, or sustained oxygen desaturation, or appearance of unstable arrhythmias. So these are the conditions where we have to abort the apnea testing. And contraindications to apnea testing are morbidly obese patients, and COPD patients with bad COPD status, and high cervical spine injuries, and chronic hypoxemia due to congenital heart diseases. So now coming to ancillary tests. Ancillary tests are very important if we are not able to do all the neurological examination, or if any of our neurological examinations are, we are having doubt on any of the neurological examinations. So So first coming to conditions which may preclude complete neurological examinations. Severe neuromuscular disorders like GBS or patients who are having myasthenia gravis or patients who may be having severe sensory motor neuropathy. In these patients, it is very difficult to assess for the motor responses. And high cervical cord injuries where we may not be able to do all the brainstem reflexes. And in patients who are having orbital, facial traumas or ocular injuries where we may not be able to see for the reflexes properly, pupillary reflex, or patients having ruptured tympanic membrane where we will not be able to do the oculovestibular reflex. And if we are having doubt in drug elimination, which we have given previously for treating the patient. In these scenarios and also in severe metabolic derangements also ancillary tests will be helpful. And if the whole brain death formulation is being followed and there is only brainstem pathology, so this may not be very relevant in our setting. So in these situations, ancillary tests will be very useful. And the purpose of ancillary test is to evaluate for loss of intracranial blood flow or loss of electrical activity of the brain. So the accepted ancillary tests are four-vessel catheter angiography, radionucleated cerebral blood flow scan, transcranial Doppler, EEG, CT angiogram and MR angiogram. Among all these, DSA, that is four-vessel catheter angiography and radionucleated cerebral blood flow scan are considered to be gold standard among the ancillary tests. So these are the examples of DSA. First video is the video of a normal cerebral blood flow. So when we inject into the ICA, there will be a normal cerebral blood flow into all the vessels of the brain. If you see, all the vessels of a brain have filled properly, and this is a video of a patient who sustained cerebral blood flow, who had aneurysmal rupture and was not having any brainstem reflexes. If you see in the second video, none of the blood vessels above the inside the cranium are filling. Only the blood vessels in the neck are filling. Whereas in the first video, if you see, all the blood vessels are going properly up. That means all the cranial blood vessels are filling properly. And in the second video, only the blood vessels up to the clinoid segment are filling, and the blood vessels inside the cortex are barely filling. So this is the example of brain DSA in brain death. And radionucleotide scan in brain death. So a radionucleotide scan helps in identifying the perfusion of brain with the help of radionucleotide substance, which is injected to a patient and waited up to 30 minutes also. The first images show the proper uptake of a brain and the enhancement of vessels inside the brain when a radionucleotide is given. And whereas the second image shows there is no uptake of radionucleated material into the brain. So we can compare the first images with the second images. And in the second images, the extracranial blood vessels are filling properly. The extracranial blood vessels in the neck are filling properly, and one central hot signs like hot nose sign are seen in images in patients who have brain death because of the extensive filling of the extracranial circulation. Next is transcranial Doppler. Transcranial Doppler helps in identifying this. The first image is the normal transcranial Doppler with a good systolic flow and a dichrotic notch and a diastolic flow. That is the first image. I am not having a pointer here, but the first image is showing a normal blood flow. So this is a normal blood flow with a good systolic peak and a dichrotic notch and a diastolic flow above the baseline. As the mean arterial pressure rises, as the ICP rises, slowly the diastolic flow will get dampened and there will be only systolic flow. As the further rise in ICP, there will be diastolic flow reversal. That means the systolic blood will be flowing into brain and the diastolic blood will be flowing out of the brain. There will be reversal of diastolic blood flow. And if it goes beyond that point, there will be small systolic peaks but with no diastolic flow, and further there will be blood flow into the brain as the ICP keeps increasing. So this is the example of a systolic flow with no diastolic flow, and this is the example of systolic flow with a diastolic flow reversal. and this is the example of small systolic peaks. So all these signs like systolic blood flow with no diastolic flow reversal, and small systolic peaks are examples of patients having brain death and no cerebral circulation. And EEG helps in identifying loss of blood flow, loss of cranial blood flow. In some places, VSA may not be available, so CT angiogram will help us in identifying the opacification of cranial blood vessels, and even the non-opacification of veins like vein of Gall and straight sinus and cerebral veins also helps in identifying indirectly the brainstem death. So, determining the brain death in ECMO patients is almost same like the normal patients, including the clinical examination. But in patients who are in veno-arterial ECMO, the arterial blood sample should be simultaneously drawn from patient's arterial catheter, and oxygenator should ensure the pH and carbon dioxide in the cerebral circulation properly. So in therapeutic hypothermia, at least 24 hours we must wait before reheating the patient, before rewarming the patient. And the patient's temperature should not be less than 36 degrees centigrade when we are doing all these tests for brain death. And communication about the brain death, and communication should start from the point of examiner believing that patient might be having a brainstem areflexia. And in addition, timely communication and clear and consistent communication is necessary. And the practitioner should be empathetic when we are communicating about the brain death. And it is, actually I was having many doubts on this slide, but after listening to Gopal sir's talk, I got clarity. So there is no need of consent for doing the brain death because it is a clinical examination. And how long should we wait after we think that patient is brain dead? So we can wait up to 48 hours, but this is not based upon the Indian law or the law of our state, but the laws which were set in US and US particularly states that after clinical examination shows a brain dead status, we can wait up to 48 hours so that we will be giving some time for the family members to digest things. And after 48 hours, patient can be weaned off from the supports. So concluding, a systematic approach should be will help us in clearly establishing the brain death, and a prerequisite should be checked, etiology should be established, and irreversibility also should be established, and confounding factors should be delineated before going for examination, and a detailed clinical examination should be done, because clinical examination is one thing which is irreplaceable, and ancillary tests will just help in supporting our clinical examination, or in rare scenarios where we are not able to do clinical examination, ancillary tests will be useful. And finally, empathetic communication is needed. Thank you.
Thank you, sir. I now request Dr. Srikanth Reddy, sir, to hand over a token of appreciation to Dr. Ranjan, sir. Next, we welcome Dr. Abdul Qadir Khan, sir, a frontline critical care expert who plays a pivotal role in managing ICU protocols and donor stabilization. Sir will be speaking on maintenance of a brain dead donor, a key to ensuring successful organ retrieval. We welcome you, sir.
Good morning, everyone. At the outset, I would like to thank Ghanshyam sir and Society of Neurocritical Care for giving me this opportunity to talk on the management of organ donor. From the morning classes, we have seen how the legal framework for organ donation, brainstem declaration, and the pathophysiology of organ brainstem death or brain death patient. So in my next slides, I will be covering about how to maintain the patient who is a brain dead. So that is a potential pivotal role for a good outcome of an organ donation. If a patient is being you have harvested organs and you have planned for an organ donation, if the organs are not optimally stabilized and you have transferred to the patient, or you transplant to the patient, if they are not maintained adequately, the outcome of the donor will not be so good. So as we have seen from morning, the majority of the road traffic accidents are more than 150,000 a year, and out of them only 0.8% organ death, patients who are brain dead goes for an organ donation. So increasing the number from 0.8 to at least to a good remarkable number will be helpful in managing patients who are listed for an organ donation. So increasing that number can be done only by maintaining a potential organ donor, by maintaining the adequate physiology and post-op and recovery of the patient. So maintaining the physiology as close to the normal of a living or living human being is important in terms for a potential and good outcome of an organ donor. Shift of focus from optimizing cerebral perfusion pressure to maintain the hemodynamic instability in patients who are having brain death is a pivotal role in potential better outcome of the patients who are having organ donation. So the demand for the organs and the poor supply is the main concern here. So the critical care or an intensivist plays a pivotal role in maintaining the hemodynamics, the ventilation, the thermoregulation, the endocrine management, the renal functions, and all acid-base abnormalities. If these things are properly preemptively optimized in the patients who are going for an organ donation, that the outcome of patients who have been transplanted will be good. So organ donation rates in India are very minute as compared to other countries. We have been discussing since morning. So we can increase the outcome of the patients by maintaining a proper in-prop monitoring or a ICU management of a patient of an organ who are a potential organ donor. So that helps in a good outcome of the patient post-transplantation. So as we have seen here, the rate of organ donation is very low as compared to the other countries, and majority of the patients, more than 1 lakh patients will be in a waiting list for an organ, for waiting for an organ. So by increasing the outcome of the patients or by maintaining a organ donor, a good outcome of the patients, and can increase the number of the potential organs that can be harvested and can be gone for a transplantation. Only 58% of the potential donors can become an organ donor if they are properly maintained in an ICU with the proper hemodynamic maintenance, endocrine management, respiratory function, and thermoregulation. All these things contribute to the outcome of the patient. What is the role of intensivist in a potential organ donor? It is helpful in maintaining the hemodynamic instability, diagnosing the organ neurological death, preparing the family in devastating conditions, counseling the family for end-of-life care, and the diagnostic criteria which we proceed further for diagnosis of brain death, and implementing policies and protocols for organ donation, and communication with the transplant team is a main pivotal role, and that helps in coordination between the family and intensivists and all transplant physicians and transplant surgeons. And the organ procurement should be done within 30 hours of a brainstem death, so that to prevent the potential loss of a patient and the organs which can be, subsequently the loss can be because of the cardiac arrest which will happen. So brain death patients has to be managed as early as possible, optimized, and then can be proceeded for the organ donation. If there is a delay, the patient may have a circulatory death that can become become a backlog for our organ donation. Who is a potential organ donor? As we have been discussed in the previous morning sessions, organ donor is a person who is having brainstem death that is confirmed by irreversible brain injury that leads to fulfilling the brainstem death criteria, the criteria which has been already discussed by Dr. Ranjit. So I will not be going in detail. And the next will be how we maintain the care of a potential organ donor comes the most important thing. One is to maintain a bedside chest licks This can be overcome with the use of checklists for monitoring cardiovascular, respiratory system, endocrine system, the metabolic systems and all. Adequate time, as I told, the basic time from a brain death declaration to organ harvesting should be as less as possible to avoid circulatory death of the patient. And protocolized approach. A protocolized multi-system ABC approach is helpful in donation, and it is being recommended. The ABC approach is nothing but to find out the cause, etiology, brain death alert signs, and any contraindications which are there for any organ donation. The flowchart of ABC approach starts with detection of potential brain death, diagnosis by etiology, and to ruling out any contraindications, family counseling, maintenance of patient or brain dead patient in an ICU, communication with the transplant team, anesthesiologist, and if at all we are transferring the organs to other state, so all those things, proper communication has to be followed, and feedback and debriefing should be done. What are the simple methods which we can use in the ICU to maintain potential organ donor is maintaining a systolic blood pressure of more than, we call it as the rule of 100, maintaining a systolic blood pressure of more than 100, urine output of 100 ml per hour, PO2s of more than 100 mm of mercury, HB of more than 10 gram or 100 gram per liter, blood sugars more than 100 mg per dl. The pathophysiology of brainstem that starts with irreversible cessation of the brainstem functions because of the decrease in the blood supply, ischemic insult which affects the brainstem, initially the medulla, then midbrain, pons and the medulla, that leads to sympathetic overstimulation. The sympathetic overstimulation is followed by a secondary phase which is followed because of the ischemia, there will be blockade of parasympathetic nucleus, vagomotor reflexes will be stopped. So initial sympathetic stop followed by parasympathetic blockade can cause a reflex which is called as Cushing reflex. It is important for maintaining, which is important criteria for a brain death. The patient will have initial hypertension, then bradycardia, and then followed by hypotension because of the blockade of the sympathetic stimulation. And the spinal ischemia, which happens, results in vasodilation and cardiovascular instability that can also be a contributing factor to your neurogenic pulmonary edema. So the multi-system effects which happens because in a brain death patient is cardiovascular. Cardiovascular, as I told, because of catecholamine surge, we'll have a sympathetic storm that can initially causes hypertension, bradycardia, followed by hypotension. Respiratory system, because of the spinothalamic vasodilation, the tracts which are coming down becomes vasodilation, and that can be one of the reasons for neurogenic pulmonary edema. Endocrine dysfunction, because of the center which gets affected because of the hypothalamus and all anterior pituitary, the decrease in the ischemia, which is because of the brain death, that affects your anterior and posterior pituitary, that can cause the dysfunction of your thyroid gland, your responsibility for your corticosteroid insufficiency. Inflammatory response because of cytokine release, coagulation abnormalities, maybe because of the hypothermia, hypertension, and acidosis, which leads to coagulation abnormalities. Metabolic derangements can be because of the endocrine dysfunction. So how we manage in ICU is by starting with a laboratory basic panel. We start with blood grouping, respiratory function assessment, liver function assessment, kidney function assessment, creatinine, electrolytes, serological testing, viral markers, monitoring of arterial blood gas analysis, and urine outputs, lactates, blood sugars every second hourly. An additional test may be required for multi-organ donor, for example, echocardiography for monitoring the hemodynamics, and bronchoscopy if the patient is being planned for a lung transplantation. We also should think that the patient who is being in the ICU for a patient who has brainstem death or being in the ICU for any irreversible cause of death, he may be there in the ICU for a longer duration, so the acquiring of infections is very high. So infection screening should be done if the patient is staying in the ICU for more than 72 hours. Preliminary cultures should be taken, and if the patient is planned for a lung transplantation, we have to do a bronchoalveolar lavage to know if any specific organisms or any source of infection is there in the respiratory tract also. The pathophysiological changes happen in the cardiovascular system because of the brainstem death, as we have discussed, is because of catecholamine surge initially that causes a sympathetic storm, initial tachycardia, bradycardia, followed by a cardiac failure because of the decrease in the sympathetic response and parasympathetic overstimulation, and then vasodilation because of the spinal cord ischemia. These factors contribute to your hemodynamic instability along with the conditions which causes diabetes insipidus can cause diuresis, fluid losses from the body, temperature dysregulation because of loss of the hypothalamic thermoregulatory control center, and hormonal imbalance. All these factors contribute to the hemodynamic instability of the patient. If you have to maintain a normolemia or a normal pressures in our map of more than 100 as we discussed, we have to maintain all these factors. So there is a VIP approach, what we call it as in maintaining the hemodynamics of a patient, that is maintaining of ventilation, intravascular fluids and pressure response based on the patient condition. So it is not a blanket thing to cover everything. So based on the patient requirement, you have to tailor your treatment starting with your intestinal intravenous fluids, pressure response, pressure therapy and all. So there are main three factors which contribute to the hemodynamic instability. It can be because of the hypovolemia, because of polyuria, diabetes insipidus which becomes a contributing factor to it, contractility dysfunction because of the catecholamine storm, and then followed by disruption of the catecholamine response and parasympathetic overstimulation, and then followed by decrease in the vasomotor tone because of the spinal ischemia. All these things contribute to your hemodynamic instability. Preload you can increase by administering intravascular fluids and treatment of DI by giving vasopressin analogs, and increasing the chronotropy by contractility you can increase by inotropes like norepinephrine or dobutamine can be used. Initially dopamine was tried, but later on because of the contradictory effects of dopamine it was later on weaned off. And pressure monitoring by devices to monitor maintaining a map. Arterial waveform pressures should be controlled and properly monitored, and maintaining a map. So as I discussed, hypertension is a temporary thing. So you need not overzealously correct that hypertension which happens because of the brainstem dysfunction. You have to use a short-acting agents like esmolol and labetalol or hydralazine can be used to counteract that hypertension. Hypotension, three-way approach, giving fluids and pressure response and hormonal replacement therapy, because the hormone, as we said, there is an endocrine dysfunction which happens and there will be corticosteroid insufficiency. So your vasopressor response may come down, so you have to give a hormone replacement therapy in maintaining patients who are having shock. So fluid of choice is a balanced crystalloids, and subsequently initial you give with Ringer's lactate or a normal saline. Later on you can, if the patient is going into hypernatremia, you have to change your choice of the fluid. Colloids are usually not used because of their immunogenic reaction and inflammatory response that can become a contradiction. Later on in a post-renal transplant patient, the inflammatory response can cause damage to the graft. Blood products, correction hemoglobin maintaining a target of more than 10 is advisable. So if you have to give colloids, the colloid of choice will be albumin. Fluid assessment, you do bedside assessment by monitoring MAP, bedside echocardiography, velocity time integral you regularly do. To assess the cardiac function, you check for RV function, LV function, and urine output you have to monitor. It should be like 1 to 3 ml per kg, and also you need to rule out diabetes insipidus and decreasing the dose of vasopressor response to maintain the MAP of around 60 to 65. Advanced hemodynamic parameters can be used like pulse pressure variation. Cardiac index becomes a doubtful thing because of the vasodilation effect which will be present because of sympathetic instability and spinal tract ischemia. Central venous oxygenation more than, it can be again more than, that becomes a confounding factor because of vasodilation. SCVO2 can be more than 70. Liberal fluid balances in patients who are not going for lung transplantation can be done, but if the patient is going for a lung transplantation, the liberal fluid strategy should be avoided to overfill the lung or to increase extravascular lung water will be more. So avoid liberal fluid strategy in patients who are going for a lung transplant. Vasopressor of choice, as per the Canadian guidelines, vasopressin is the first choice to be used in patients who are hemodynamically unstable, cardiovascular instability. Norepinephrine can be used. Dopamine initially was used, but later on it is being avoided because of the adverse effects of tachyarrhythmias. Dobutamine and epinephrine remains the choice in patients who are having cardiac dysfunction, and in patients who we have to increase the myocardial contractility, you have to use epinephrine or dobutamine. Phenylephrine is again contraindicated because of the vasoconstrictory effects, and excessive vasoconstriction can cause decrease in the organ perfusion that can again decrease your graft rejection, and graft function can be hampered. High dose epinephrine, again, it can cause tachyarrhythmias. That dose should be tailored and it should be maintained targeting MAP of not more than 65. So don't give a high dose of epinephrine or any vasoconstrictive agents that can decrease your organ perfusion. Hormonal replacement therapy, as I told, the patients will have corticosteroid insufficiencies, which can lead to your hemodynamic instability as well. So minimal hormone replacement therapy has to be done. Vasopressin as a replacement dose of 0.01 to 0.04 units we start. We also give methylprednisolone at a dose of 15 mg per kg. Insulin, we have to maintain normoglycemia, not target tight control glycemic regimen should not be followed. Thyroid replacement therapy, all these things, hormone replacement is also important factor in maintaining your hemodynamic maintenance of the patient. Monitoring tools, as per your ICU structure and design, you can use advanced monitoring tools or basic monitoring tools of arterial pressure monitoring. If you have a LIDCO or cardiac output monitoring, you can use that. Pulmonary artery catheter has also been used, but that is not the recommended strategy. If you have a basic mean arterial pressure monitoring, that is good enough for monitoring your MAP, and also pulse pressure variation can be monitored. Endocrine dysfunction, brain death damages the hypothalamus and the pituitary, which is the most important, plays an important role in your secretions of our anterior pituitary and posterior pituitary hormones. And hormone deficiency happens. Clinical manifestation can be diabetes insipidus, hypothyroidism and hypocortisolism. Diabetes insipidus occurs in patients, 80% of the patients with brain death. But if the patient doesn't develop diabetes insipidus, doesn't mean the patient is not brain dead. So that is not the only criteria. If the patient develops DI, then only the patient is brain dead. You manage by giving vasopressin replacement dose, and also by maintaining fluid. You have to replace your volume, and you have to monitor hyperosmolarity, urine specific gravity. Your specific gravity, if it is less than 1.005, then it fits into the criteria for diabetes insipidus. And hypernatremia should be monitored because it becomes more than sodium of more than 155 becomes again a contraindication in patients going for a liver transplant. So the diagnostic criteria is urine output more than 3 liters per day, specific gravity less than 1.005, and osmolarity, urine osmolarity less than 200 is a criteria for DI. And blood parameters, hypernatremia going to more than 150, serum osmolarity more than 295. Patients may also have, along with it, hypokalemia, hypocalcemia, hypomagnesemia, and hypophosphatemia. The clinical signs of dehydration may be present. The monitoring, management of a DI includes fluid, as I told, fluid administration becomes a standard of first thing. Administering fluids, balanced salt solution or renal lactate can be used. If the patient is having DI with hypertension, you have to start off with vasopressin as a replacement dose, 0.04 to 0.01 to 0.04 units. In patients who are having DI with hypernatremia without hypertension, desmopressin is a choice of agent. Thyroid hormone deficiency also occurs because of the pituitary dysfunction, and patients have to go with a thyroid replacement therapy with a dose of thyroxine. And in patients may have sick euthyroid where thyroxine levels may be normal, but TSH may go up high. So they are having sick euthyroid syndrome. So these patients also have to be replaced with thyroxine. Corticosteroid deficiency can be occurring because of the HPA axis failure, inflammatory response, and the benefits of corticosteroid, as I discussed earlier, to maintain the hemodynamics, to maintain the sugar glycemic control, and also to maintain thermoregulation is more important for benefits of corticosteroid. So administration of corticosteroids, we use methylprednisolone at the dose of 15 mg per kg body weight. Hyperglycemia occurs because of the insulin resistance and also decrease in the insulin synthesis and increased gluconeogenesis because of the stress response. If untreated, hyperglycemia may be dangerous and can cause pancreatic damage. So the patient cannot go for a pancreatic. If the patient is planning for if the patient is being kept ready for a harvesting of pancreas, that becomes again a contraindication. The patient is having hyperglycemia. And even if hyperglycemia is there, don't target for a tight glucose control. It should be a liberal glucose control should be there. If the patient is going for a lung transplant, respiratory management becomes an important factor. And as I told, when the spinal ischemia happens and vasodilation occurs, that leads to a neurogenic pulmonary edema in these patients. So administering liberal fluids can cause further worsening of this pulmonary edema. So you have to avoid liberal strategy of fluid administration in such patients, and you have to plan for doing a infective screening also by doing a bronchoscopy to rule out any other infections if the patient, if you are going for an organ harvesting for lung. How to manage a lung? It is by lung protective ventilation strategies. The ideal volume you target at 6 to 8 ml per kg. PEEP at an optimal PEEP of 8 to 10 mm, targeting PaO2s of 100. And alveolar recruitment maneuvers after any disconnections or if the patient is not able to maintain oxygenation. And the use of continuous positive airway pressure is also being tried in patients who are going apnea test. If they are not able to maintain oxygen, you can give CPAP and then you can do an apnea test. The targets are pH of 7.35 to 7.45, PaO2 of 100 mm of mercury, SpO2 target is 95 and PCO2 is around 35 to 40. The respiratory target should be maintained to ensure optimal organ preservation, especially for potential lung donation. If you are planning for a lung donation, these targets has to be followed. Renal tubular injuries are caused by the pro-inflammatory responses, systemic inflammatory response which happens in a patient who are brain dead. These can cause renal injury, renal tubular vasoconstriction. Appropriate fluid management for a renal patient who is going for a renal harvesting is important. Inflammatory mediators which releases the renal tubular, it can cause renal tubular vasoconstriction. And overzealous administration of your normosaline can cause metabolic acidosis, that is hyperchloremic metabolic acidosis. So that has to be avoided. Hypothermia, because of the dysregulation of your hypothalamic temperature regulatory center, the patient may land up in hypothermia. Then again, hypothermia becomes deadly coagulation cascade abnormality, which can cause coagulation abnormalities, temperature loss, vasodilation, heat loss from the body. All these things contribute to your hypothermia. Correction of hypothermia happens with surface warming, warm blankets, and administering of warm salines. And if all these things are not, if your temperature cannot be maintained by all those things, then you have to go with intravenous warming devices also. Anemia occurs because a patient, mainly brain dead patients go with trauma, so they will have a blood loss, so they will have anemia, and coagulopathy happens because of the hypothermia, and also by overzealous administration of fluids can cause hypocoagulability and coagulation abnormalities, and by releasing of your inflammatory cytokines also can cause your coagulopathic conditions. As I told, infections are not the contraindications for your organ donation, but if the patient stays a significant amount of time in your ICU, they are more prone for infections. Gram-negative infections are more common. If the patient directly comes from a community and you have been declaring the patient as a brain dead, so gram-positive with gram-negative infections can be there. So any infection is not a contraindication. in the organ donation program becomes equally important and becomes equally responsible for the good organ, healthy organ for a recipient. Share life to save lives. Organ donation becomes an important part of our daily thing which we have to consider, and to prevent organs being wasted. So promote organ donation programs at your hospital and improve the quality of an outcome of the patients. Thank you.
I now request Dr. Srikanth Reddy sir to hand over a token of appreciation to Dr. Kadir sir. We are truly honored to have with us one of the most distinguished names in critical care medicine, Dr. Rahul Pandit sir, who currently serves as a chair critical care at Sir H.N. Reliance Foundation Hospitals, Mumbai. Sir is not only a highly respected clinician, but is also a national thought leader in policy and preparedness. He was a key member of the National COVID-19 Task Force formed by the Government of India and continues to play an instrumental role in shaping ICU protocols, ethical organ donation frameworks, and trainings across the country. We welcome you, sir.
Thank you very much, SNCC, Dr. Ghanshyam, Medicover Hospital for the kind invitation. Over the next, can I have my slides please? Thanks. Over the next 20-25 minutes, I would be covering up some real life scenarios which have happened and difficulties which we have faced. Now, obviously, they are not, all of them are not from my hospital, but I happen to be the chair for ICU committee for ZTCC Mumbai as well as for the Roto West, and I'm also committee member for the Noto as well. So a lot of people across the country call me up for brain dead declaration and problems with that. What do I press? The green button? Green button. Okay, so these are some of the 8-10 cases which I have selected today. They depict the common problems which we feel are easy to solve, but sometimes they actually cause a hindrance in the declaration of brainstem death. So this is going to be a little interactive session. I would like some crowd participation in this. So this is the first case. A patient flexes their arm at the elbow following imposition of painful stimulus to the nail bed on that side. Is the patient likely to be brain dead, or the patient is not going to be brain dead? Any thoughts on that? Who says the patient could be brain dead? Hands up. Okay, we've got few. Who says the patient can't be brain dead? Only a few hands up on both the sides. Most of the audience are muted on the thought process. They are not talking about it. Now, remember, the way to give painful stimulus, we are giving a deep, central deep painful stimulus to the patient. What does central deep painful stimulus mean? That you have to give a stimulus, preferably where afferent and efferent both are in a cranial nerve distribution. Now, which are those 2 or 3 points where cranial nerve distribution will have afferent and efferent? You have your medial canthus above the eye here, just lateral to the nose bridge, which is the ophthalmic branch of the trigeminal nerve. Or you could have your spinal accessory squeeze of the trapezius muscle, which is the spinal accessory nerve here. Or you could do a typical anesthesia jaw lift, which actually gives you a central deep painful stimulus. When you press on the periphery, you are actually stimulating the dermatome. You are not stimulating the central deep painful nerve. So there you may represent a spinal reflex. So this particular thing could still represent a spinal reflex, and you could still have a brain dead declaration possible with this. So don't be perturbed. While we all want to give a graded reflex in terms of painful reflex to a patient, we don't want to go and straight away do a deep painful stimulus to the patient. We all should be worried about the spinal reflexes. Second, please do not give a sternal rub. By all means, sternal rub is a painful reflex, but it is not stimulating the central area. It is stimulating a spinal dermatome. So again, a painful reflex on the sternum for a patient who is brain dead will not represent your actual need to simulate the central area, which is going to be the cranial nerve distribution. Second case, patient sits up. I think Dr. Ranjit, was it? He talked quite nicely about Lazarus reflex. Now, Lazarus reflex, essentially, Lazarus means coming back to life. That's what Lazarus means. And there are stories which, if you look into Google, Internet, PubMed, you will see hundreds of stories of Lazarus reflex being seen, typically been described as a patient was being taken for organ donation and the mother hugged the patient just once before the patient was supposed to go to theatre, and the patient hugged the mother back. Obviously for the mother that's a big thing because both the arms came up. And again, Lazarus reflex is a very, very known entity. It can be stimulated by a movement of head, it can be stimulated by a movement of limbs. It is quite possible. It happened with me once, and I will never forget that. This was in Fortis Hospital around 8-9 years ago. What I do is I am very comfortable having my patient's family along with me when I am doing the brain dead testing. It helps me to sort of convince them without speaking a lot of words, because when they see the testing being happening, they actually realize that the patient is not breathing, despite the ventilator being disconnected. They see all the brainstem signs. Of course, I do a lot of counseling that what am I going to do before we take the patient's family inside. I offer them, many of the family members say yes. In this particular case, it was no different. I had explained to them, but I had not explained the Lazarus reflex to them. And while we were doing an apnea test, around 4 or 5 minutes into the apnea, literally, and this was the most violent Lazarus reflex that I have seen personally, the patient actually, the whole body went up by around 1 feet or half a feet, I don't know how much, but the patient actually went off the pillow and then flashed back onto the bed. And it was really perturbing to everybody. So what we did was, we obviously abandoned the case on that particular day. I spoke with the family again. The family was motivated to donate. So we went through the whole process again next day, and then we could complete the donation in this case. But I wouldn't be surprised if a lot of patients now start having a mistrust in you or completely abandon the process and actually want to consult another doctor. That is also possible. So now I also talk about Lazarus reflex as well. And this is a very important thing which we need to understand. I've got a few more cases where I've gone through this, and this has been learned through the cases which I have either experienced myself or I have sort of been consulted for. This was a few days ago. A 22-year-old alleged history of unknown poisoning. So patient was found unconscious, was brought, no empty packet or any tin or anything found near the patient, but definitely it looked like a toxicology thing. As you all know, the gastric aspirate never comes back on time for us to actually tell what was the toxin which was taken. Patient was deeply comatose, and in 48 hours, apnea test was done and both the certifications were done. There was no documented cardiac arrest, hypoxia, trauma, and the cause of death was metabolic encephalopathy. Can a cause of death be a metabolic encephalopathy? Yes? Anybody who can say metabolic encephalopathy as a cause of death? Metabolic cause is typically reversible. You cannot say metabolic encephalopathy as a cause of death. Now remember, any poisoning, if you are not very clear what the toxin is, I have personally again have 2 patients in the last 24-25 years where I have seen crate bites, 2 crate bites, and I'm sure those who have seen crate bites, if they come to the hospital without a cardiac arrest and they unfortunately go into a complete neurological paralysis, they behave exactly like brain dead. Their pupils are fixed and dilated, there's no dolce, there's no cough, gag, they're not breathing. You look after them properly for 3 to 5 days, they wake up as if they have woken up from an anesthesia. All the reflexes come back, they are fine. Organophosphate poisoning, diazepam or overdose, they will all have blunted reflexes. 3 days ago, I had a patient on very high inotropes, fixed dilated pupils. Everybody was saying patient has got a hypoxic brain damage. Yesterday morning, and I'm not making this up, yesterday morning I've extubated that patient. So just be worried about this fixed dilated pupils not reacting. Be very, very clear. The first step of brainstem death is, do we have a diagnosis which is confirmatory that will progress to brain dead. If you don't have a diagnosis which is clear, so you don't have hypoxia, you don't have trauma, you don't have bleed, you don't have infection, you don't have infarction, subarachnoid hemorrhage, trauma, so on and so forth, take a step back, rethink. You may not be having a patient who would become brain dead. You may have a patient who may be metabolically unwell and may be behaving like a mimic of a brain dead. So just be very clear about that. Always, always, always have some form of a neuroimaging. This thought process of a lot of people that don't do a neuroimaging is actually dangerous for our own sanity, mind clarity, legally. Just do some brain stem, some either MRI of the brain or a CT scan of the brain, which will demonstrate to you that whatever clinical thought process was is consistently documented in that as well. You may have an early traumatic brain injury, which may then progress after 4 days. I don't want you to do a CT after 4 days, but if you've done an initial CT which demonstrates traumatic brain injury, that's fine. Then when the patient progresses on, it's under your vigil, under your ICU, you'll be able to then say that yes, there was an injury which has now progressed to brainstem death certification. This is another patient. This was very funny. Patient had a surgical procedure, decompressive craniotomy around 50 hours ago, and patient had a trauma. Basically, was clinically brain dead. They went ahead with the declaration, but one of the anesthetists brought up that we've used sevoflurane, and this was the reference they sent me, which says that some sevoflurane is still not metabolized for several hours, including up to 96 or some hours after the anesthesia has been given. So general thought process is that if you've actually cleared the gases completely, you don't worry about any residual effects of inhalation anesthetic agents. For other agents, which are IV medications, either sedatives, hypnotics, or muscle relaxants, for muscle relaxants always use a train of 4, and if you have 4 twitches seen on either one of the nerves that you stimulate, you are very, very clear that there is no residual effect of muscle relaxant. For other drugs, make sure that you have 5 half-lives, at least 5 half-lives being waited for, in presence of normal liver and renal function. If your renal and liver function are abnormal, then think about dialysis sometimes if you are in a hurry. If you are not in a hurry, if you could wait for several more hours, you wait. It's more of a clinical decision. No law, no guideline is telling you what to do. It is your pharmacological of the call was that we have waited for 50 minutes, 50 minutes, and the patient's CO2. Cardiac patient, as rightly mentioned by Dr. Ranjit before, you have to wait for 20 above the baseline. The reason is that your brain respiratory center gets stimulated by the acidemia caused in the blood. So you have to stimulate acidemia. So if you can bring up acid in the blood by increasing the CO2 adequately, and then demonstrate that despite the stimulation, the brain function is not working to stimulate respiration, that's when you call that apnea test is positive. So you can't say, I've got one more case in there, where you start with a CO2 of 20 and bring it up to a CO2 of 50 and say it's 20 above the baseline because I hyperventilated the patient before and now it's 50 and now I'm going to declare this patient brain dead. No. Acidemia is demonstrated after 60 millimeters of mercury. All societies, papers, thought processes, they actually go across with that. How did they come to that number? They actually did the pH of the CSF. And the CSF pH demonstrates significant amount of acidosis when the PCO2 goes above 60 in a patient who has got a otherwise normal PCO2 at baseline. So that's where this number of 60 comes up in place. This is the ABG. You can see this is a pre-test, first apnea test, pre-test of the ABG and a post-test ABG. Any red flags there? Sorry? Hypernatremia, yes. Now, hypernatremia, as we all know, in the majority of the cases, I would say 99.9% of the cases is a effect rather than the cause. Because of brain death and because of poor management in the intensive care unit, large volumes of urine is lost, free water is lost, and these patients have significant rise in the serum sodium level. And it can easily be corrected. So why have I kept this? To dispel 2 or 3 myths. One, it is a preventable problem. So if you have a good intensivist, which nowadays I don't see a lot of hypernatremia, a lot of people are sensitive about it. As soon as the urine starts to pour out in large numbers, large volumes, we start replacing it with free water or 5% dextrose. So one, we have been given a responsibility to declare patient brain dead when physiologically normal parameters are met. Sodium is one of them. So in Maharashtra and Western Roto, they have accepted a sodium up to 160. If it is up to 160 or low, we will go ahead with the brainstem dead testing and accept that test. Ideally, in most ideal cases, which I want to do and which I do in my unit is I keep it normal, which is below 150. So if you keep it below 150, there will be no questions asked. Second, if you have this kind of a high sodium, don't be worried about correcting it rapidly. That has also come to me, that now I will correct it at 10 millimoles per day because this patient is brain dead. There is going to be no central myelinosis, which is pontine myelinosis, which the patient is going to get. So don't worry about rapid correction. You can actually correct it within 6 to 8 hours very, very quickly. Third, the argument that it is a cause rather than the effect and not the cause does not stand true. Always correct the sodium to the best of your ability, bring it as low as possible and then move forward. Another case, this is a patient with severe aspiration pneumonia. PO2 was 264 and FiO2 of 1, which is a PF ratio of around 264. Patient's doctors attempted apnea and patient kept on desaturating. How would you do an apnea test? Remember, ancillary tests were discussed. Now, unfortunately, ancillary tests, well, I don't agree with that. The science is very robust for ancillary tests as well, so it's not my thought or my opinion. Ancillary tests, unfortunately, are not acceptable right now to declare a patient dead. You have to do a clinical brain death testing. That's what the law says. And I have been sort of fighting this at a lot of levels that we need to include ancillary tests where we are not able to do an apnea testing for some reason, or you're not able to do a complete brainstem dead testing for some reason, like a high cervical spine injury or a profound hypoxemia. What do we do? So how would you do an apnea test in this patient? Any thoughts?
Induced hypercapnia?
Sorry? So you could either use a Bain circuit, just keep a half valve open and use it, or you could use a CPAP. There is a paper which has come out which talks about using continuous positive airway pressure as well, and that could help you to have a little bit of positive airway pressure going on continuously while the apnea test is done, and you could then have an apnea test completed. I must have done at least 8 to 10 patients on a Bain circuit, and I'm extremely happy with Bain circuit as well. While CPAP can be easily attempted as well, but it has always bailed me out wherever there has been a hypoxic patient where I have not been able to do a brainstem dead testing in a conventional way. So I just attach a Bain circuit. It does take a little bit of time. I don't keep the flows to around 12 to 15 liters. I try to keep it around 8 to 10 liters. Keep the half valve open. The bag acts like a reservoir. It tells you whether breathing attempts are there or not. And then you continue looking at the CO2 and see how the rise of the CO2 is. Again, this was a patient already reported to Roto. The regional organization did not find anything. Roto wanted to distribute the organs. Anything alarming here? Any red signs here? So two problems there. One, image is not very good, which is, I really doubt the image there. One, the patient is profoundly acidotic to begin with. Two, the potassium level 2, just 2.0 or 1.94. Hypokalemic periodic paralysis or low potassium will preclude your response to deep painful stimulus or breathing efforts. So again, this ABG is not a very good ABG to actually say that this is a pre-test ABG. I would want to check the acidosis a little bit more before we decide to go ahead and do a diagnosis, do a brainstem dead testing. Now these are all real cases, these are not ABGs made by me. I've just put together the numbers there. Okay. Sorry. How do I go back? This was another thing in there was the PCO2, which was I was mentioning. The PCO2 was 21 to begin with, went up to 56, and the argument which was being given to me was it's 20 above the baseline. We just went through that discussion before. Another case, patient declared dead. What is the problem here? Again, sodium is the issue here. Generalized tonic-clonic convulsions. This is a case from Nanded. They asked me, can we declare patient brain dead? Patient is not responding. Any convulsive activity, whether generalized tonic-clonic or non-convulsive status, is contraindication to a progression of brain dead. Okay, so no brainstem death. If there is it actually demonstrates there is an intact neural connection to have a grand malfit. This happened with me. I have never forgotten this. This was a young guy, high-ranking civil servants, both the parents, husband, wife. Unfortunately, the boy committed suicide by hanging himself. Was brought to the hospital, our hospital, with profound hypoxic injury secondary to a cardiac arrest and hypoxia secondary to hanging. We resuscitated him. We got his Ross back, took him to ICU. He progressed on to become brain dead. And the family was very well educated, well aware of what the processes are. So they agreed that we would like to do a brain dead testing and see if he is brain dead, and then we think of organ donation. So this actually came up upfront from them. So we went ahead and we did brain dead testing, and then when the time for organ donation and discussion about declaration for dead happened, both of them backed out. They said, no, we just wanted to test whether what is happening. We don't want to continue care. Anyways, so with this, they also had a very vigilant eye and attention for detail for everything. They would not allow any de-escalation. They would sort of keep on interfering into the treatment. They would bring in all sorts of health secretary, health minister, everybody was sort of getting involved. But needless to say, in around 4 to 5 days' time, the heart stopped because the patient was brain dead. Now, as per the law, it was a medical legal case, so I referred to the postmortem. This is where my troubles became. I got into a lot of trouble. The trouble was that we had already declared the patient dead 4 days ago, and I had written in the notes patient is dead by brainstem death criteria, and request for organ donation to the family to be done. This is what my paragraph was after doing the second test. I had done the second test. The time of brainstem death is so and so date. Patient's family brought in the police. Obviously, they were IAS officers, so IPS officer came up directly, the local big guy of the police station of the area. And then he is telling me that why have you kept the body for 5 days in your hospital? So, Marathi mein he was trying to tell me, 5 दिवसापासून तुम्ही याला ठेवलं इथे, त्याचं काय justification आहे, doctor said. Now, obviously, when the concept what Dr. Gopal also mentioned, that ideally we should be able to have a uniform declaration of death, and we should be able to sign a death certificate saying that patient declared as per brainstem death criteria, which we are not able to do. Again, we have been fighting it at a lot of levels, including the central government level, but it has still not happened. It's work in progress. A lot of aji-baji discussions happened over the day. Ultimately, all of this was done to avoid post-mortem. That was the bottom line of it. And I put my foot down. The hospital supported us completely into this process, which was good. And then the body was handed over to the family. The time of death was put as cardiac death. So I had to take a back step and say that cardiac death, that day whenever the heart stopped, we had to actually put that as a cardiac death and we went ahead. So these are some of the things which, yes, Dr. Gopal, you wanted to say something?
Yeah, I mean, we have gone through this situation, though not in Mumbai and Health Minister getting involved. That I was not that fortunate. But if you read into some interpretations of the brain death as in Indian constitution as of today, the opinion seems to be veering towards you cannot declare brain death unless the next of kin accept to transplant, organ donation, because it is in the context of Transplant Act that brain death is defined. In fact, I myself differed with it for almost a decade. But to declare brain death without organ transplantation and hold second brain death time as death time, we need a lot of cooperation from the patient family.
Agreed, sir. I don't disagree with that. This is the fallacy of the law right now, that the death is, the brain stem death is actually mentioned only in the TOHA Act, not in the Birth and Death Registry of India. If that is what it would have been mentioned, it would be Uniform Declaration of Death, and I don't need anything else. But in all practical purposes, it is acceptable. Now, what Dr. Gopal is saying is legally absolutely correct, factually correct. I am not disputing him, but all of us, including him, practice it in such a way that we are actually confident and we are able to declare date. And majority of the cases we don't find a problem like this, but here was the concern and here is a problem. If somebody actually challenges it in the court and goes to the court, I think we will win, because the judges would take a common sense approach and say that this law is there. But as of today, the argument can be made that there is no acceptance of brainstem death in Birth and Death Registry Act of India, and it is only pertinent to organ donation. So if organ donation is happening, brain death should be declared. Sounds a little funny if you're dead enough to donate, but you're not dead enough to be dead. So it's a funny argument to make, but that's what it is. I think this has been explained by the neurologist quite well. Some residual flow can be seen. I don't think we need to worry about some residual flow. Is that? Oh, sorry. So in up to 10% of the patients, some residual flow can be seen. Rest of them, you would obviously not have a problem. This was the last of the Lazarus reflex. Is the video working? Because it was transferred on WhatsApp. So I don't know whether the video will work or not. It's just a Lazarus reflex. Again, that was demonstrated as well. So don't worry. Thank you very much. I'll be happy to take questions if there are any. Thanks.
Request Dr. Srikanth Reddy sir to hand over a token of appreciation to Rahul sir. Thank you sir for sharing your invaluable experience and offering clarity on ground realities that every critical care team faces. Before we proceed to our next session, let us take a moment to honor tradition and illuminate our path forward with lamp lighting. I now request our esteemed dignitaries, Dr. Rahul Pandit sir, Dr. B.V.N. Gopal sir, Dr. Ghanshyam sir, Dr. Srikanth Reddy sir, Dr. Dilip sir and Srikanth sir to please come forward. I would also like to invite our CBO sir, Mr. Manish sir, to please come forward. we conclude the first session of this enriching and thought-provoking day, I would like to extend our heartfelt thanks to Dr. Srikanth Reddy sir for graciously chairing this session. I would like to invite Dr. Dhansham sir to hand over a token of appreciation to sir. I would like to ask Dr. Srikanth Reddy sir to share a few words.
I would like to thank Ghanshyam sir and the society for giving me this opportunity. Thank you. Thanks a lot.
Let us have a quick tea break for 10 minutes and we'll join here back.
technology. Why do international patients choose Medicover Hospitals, Hyderabad? Because we combine world-class medical expertise with personalized care that begins the moment you land. We offer free airport pickup and drop-off, along with a visa invitation letter to make your travel easy and worry-free. Our 24/7 multilingual translators ensure clear communication throughout your stay. With the option for prior teleconsultation, you can speak with our doctor even before you arrive. At Medicover, you have the freedom to choose your preferred doctor and unit and receive treatment from some of India's top surgeons and medical experts. Our advanced infrastructure and cutting-edge technology ensure global standards in every procedure. Post-surgery, we support your recovery through dedicated nursing care, expert physiotherapy, and reliable home care services. Conveniently accessible via major international airports, Medicover Hyderabad stands apart for not just its excellence, but for the way we truly live the Indian value of Ati Devo Bhava, where every guest is treated like family. Why do international patients choose Medicover Hospitals, Hyderabad? Because we combine world-class medical expertise with personalized care that begins the moment you land. We offer free airport pickup and drop-off, along with a visa invitation letter to make your travel easy and worry-free. Our 24/7 multilingual translators ensure clear communication throughout your stay. With the option for prior teleconsultation, you can speak with our doctor even before you arrive. At Medicover, you have the freedom to choose your preferred doctor and unit and receive treatment from some of India's top surgeons and medical experts. Our advanced infrastructure and cutting-edge technology ensure global standards in every procedure. Post-surgery, we support your recovery through dedicated nursing care, expert physiotherapy, and reliable home care services. Conveniently accessible via major international airports, Medicover Hyderabad stands apart for not just its excellence, but for the way we truly live the Indian value of Ati Devo Bhava, where every guest is treated like family.
I request everyone to please be seated as we move on to our next session. Sir. I request everyone to please be seated as we're moving on to our next session.
ఓకేనా చూడు ఒకసారి లైట్ ఫోర్కేలో చూడద్దు 4K తీస్తే అవి రాదు ఎప్పుడు అంతే ఉంటుంది
I now request Dr. Pradeep Reddy sir, Head of Critical Care at Medicover Hospital, Secunderabad, to come onto the stage. He will now speak on ethical and legal considerations in organ donations, helping us navigate dilemmas with clarity and conscience. We welcome you, sir.
First of all, I would like to thank Ghanshyam sir, my mentor for almost 20 years from now. And I'd also like to thank the Society of Critical Care for giving me this opportunity. So, here, the declaration of brain death is challenging in so many instances because a lot of ethics are involved. Though it is ethical and legal issues which I have to cover, I will cover mostly ethical issues because legal issues are being covered in 2 other sessions. That is already TOTA Act has been covered by Dr. Gopal sir, and the legal issues particularly will be covered by Purnima madam. So despite 50 years of guidelines which have been published, still there is a controversial topics which are involved, as we have discussed in the last lecture by Rahul Pandit sir, that there are so many cases where you are at crossroads of decision making with lots of legal and ethical implications. The earliest example for organ donation is the Lord Ganesha, where head has been transplanted. That is our mythology or our history, whatever we say. Human organs are most precious because they are not either sold or not bought. So with this context, we will go forward. So ethics in the field of brainstem death and organ donation came into existence after this particular surgery, that is first cardiac transplantation done by Dr. Christian Bernard in 1967. After doing this surgery in Cape Town, they have organized a press conference, and in that press conference, one journalist asked Dr. Christian Bernard, what happened to the patient from whom you have taken the heart? Is he dead or have you killed him? This is a pertinent question which provoked the ethics of the brain of Dr. Henry Beecher, who was in the audience in that particular press conference. So he went to ad hoc Harvard dean and asked him to form an ad hoc committee and make him the chairman of the ad hoc committee so that he can formulate the criteria for brain death. So in 1967, the ad hoc committee was formed, and in 10 months of time, that is in 1968, they gave Harvard committee criteria, that is ad hoc committee criteria, where brain death was defined and how to declare the laws were made. After that, after 20 years or so, 15 years or so, the President Commission was formed and the ADA Act was formed. ADA Act is nothing but Universal Declaration of Death Act. Here, they have equated cardiopulmonary death to the brain death. So, once you declare a person to be brain dead, he is dead. Then came the 1995 the American Association of Neurology Guidelines, and then came in India pertaining to our brain death declaration and organ donation. The TOHA Act and the TOTA Act have come into existence. So there are so many issues which we have to discuss in the ethical things. There are ethical importance where we have to respect the dignity of the person, we have to give autonomy, and there are practical important questions there are where who is going to declare the brain death and what is going to happen after declaration of brain death. There are legal important questions, and there are also so many cultural important questions and medical. We will see each one by one. So as we have discussed in the morning, in the first class, Madam has told that there is a growing wide gap of the requirement of organs and the need for donation. There are at least 5 lakh people who have been listed for the organ donation and organ receiving, but only we are able to harvest only few thousands of organs. And here we can see that the percentage of organ donation, that is 0.25 million per population in India. This was 3 years back. Now it has just increased to 0.6 to 0.8. So the Harvard criteria, what it has said is that because of the improved quality of care and improved services which are being provided, there is a requirement of many patients are coming to the ICU and they are occupying many number of beds. So there is increased requirement of ICU services. With this increased requirement of ICU services, is it ethical to continue somatic support on a patient who is already brain dead? Or if we say that we are going to harvest his organs and with the consent or without the consent, then what is happening to the society? Because of the growing demands, is there any social doubt which we are giving into the society? So here, these are the 4 pillars of ethics, that is beneficence, non-maleficence, autonomy and justice. These are the 4 pillars of ethics in any part of medicine, and the 5th pillar being the confidentiality. So beneficence means this is the act of, you act in the best interest of the patient. What is the dilemma of ethics here? Because the patient is not able to decide by himself, because he is already having brain death. He is not able to decide for himself. So the autonomy part is not being taken care of properly. And maximizing the recipients, benefits to the recipients comes in the form of where donation with the living donors. That is beneficence. Non-maleficence. First, do no harm. Primum non nocere. But what is happening here? In the brain death patients, you are taking out the organs. So, is it ethically right or is it wrong? What is happening with the living organ donors? Ensuring no harm. By taking out one kidney, if one kidney is sufficient, why God has not given only one kidney? Why God has not given only one lung? So you are taking out one lung, one kidney, part of liver. So if a patient is able to survive with that only, then why we are having these things? So the non-maleficence is also being contradicted here. Autonomy, respect of person's choice. So here, consent from the family members is being taken, not from the person per se, unless he is given some advance directive. So donors must make voluntary and informed consent. Here, we have to see that they are not subjected to any coercion, greed, or any kind of emotional stress. So what is justice? There should be some fairness and equality in distributing the organs. So there should not be any racial discrimination or socio-economic discrimination in donating the organs. What is directed donation? Here, if the patient is brain dead and is going to donate the organs and he is not the consent giver, the kin is the donating it to their own relatives is the question. So this is the ADDA Act. Here what happened is this ADDA Act has definitely defined brain death, equated brain death, cardiorespiratory death, and once you have declared a person brain dead, it is definitely that patient is died. But what it did not address is whether the consent has to be taken for declaring it. The TOHA Act. In India, the TOHA Act was introduced in 1994. Brainstem death is defined as brain death in India. And as part of transplantation, this year, if you are declaring a person brain dead, then it is linked to transplantation. You have to take consent for declaring the patient. You have to take consent for declaring the patient as brain dead. For as Gopal sir has said, as brain dead. As Gopal sir has said, for clinical, all the cranial nerves and all, you don't need any consent. And to for yourself whether the patient brainstem is functioning or not. But for need the consent. To do the apnea test, need the consent. To do the apnea test, yes, you very well need the consent. Yes, you very well need the consent. Apnea test cannot be done, patient's skin. So we have also incorporated diagnostic criteria similar to the criteria, that is what we are following brainstem death criteria. Here, the presumption is that the patient is alive, and what we are going to prove, we are going to disprove that the patient is alive by our examination. So again, whatever tests we have to do are to the benefit of the patient. So when we are doing some tests to disprove that he is alive, then ethical question comes into picture. So, what is the medical practice of determination of death? We have discussed, Ranjit has given beautifully the entire criteria. So, here there are 4 things or 5 things which you have to know. There are some prerequisites, that is, you should have a neurological injury. What is the next one? It should be established that it is a neurological injury which is progressive and non-reversible. So you should establish that irreversibility is there. And thirdly, you should exclude all confounding factors. And you should observe for permanency. That is the reason why you do a second test. So these are the things which you have to keep in mind while doing brain death declaration. And what will happen? There are so many controversies and inconsistencies. Why? Because who should do the test? How should the test be performed? Is there any difference in the age group? What are the confounding factors? And if the confounding factors are there, how are you going to declare brain death? Is the consent needed or not needed? Are there any regional preferences? Are there any differences according to government policies? After test refusals, Rahul Pandit sir already discussed in his case series, the last session, that there is a after consent refusal from a senior IAS officer himself. So, special situations, declaring death by neurological criteria, next what? After you declare death, next what? Then timing of death, when should the transplant coordinator be involved, and directed donation, can this the recipient request for a directed donation, and can the donor request for a directed donation, or can the recipient refuse to say that I don't want this particular organ? So these are all ethical issues. So if because of these inconsistencies, you are now facing headlines like this: a brain dead woman, Canadian woman, dies after giving birth to a baby. Already you are declaring dead. So these are the headlines which are make you think that ethics should be the cornerstone of this particular brain death declaration and organ donation, because the social milieu will be disturbed whenever you say that you are only going to harvest the organs. So it should be a voluntary thing, it should be an altruism, and it should be a personal choice. And we all know this famous case of Jai McKay, where she was diagnosed brain dead in 2013, but she survived till 2018 in another state. She was declared brain dead in one state, but another state refused to accept it. she survived till 2018. In these 5 years, she even attended her puberty. When you say that, in particularly in USA, it is whole brain which is to be failed to declare them as brain dead. When you are saying that whole brain is not functioning, how the neuroendocrine functions are functioning? And when it should be done, and what are the tests which are accepted as ancillary tests? Differences in age. Well, let us come to this. The term infant to 2 months, they say 48 hours apart. 2 months to 1 year, they say 24 hours apart. And about 1 year to 18 years, it is 12 hours apart. An adult, it is 6 hours apart. So how are these timelines determined? Is it sufficient? Accepted age limit for donation? We don't know. Can we take organs from anencephalic babies? Or can we take organs from 8-year-old? And also, does the recipient have a say in saying that, okay, fine, I want an organ from 18-year-old, I want an organ from 30-year-old? Is there any recipient who can refuse the organs? So these are all questions which need to be answered. Confounding factors, especially if you take Canada, the temperature accepted there is 32 degrees centigrade. Here we accept 36 degrees centigrade. So there are regional differences in acceptance, and these regional differences are going to cause social doubt. So you have to explore these confounding factors before you say that, okay, the patient is brain dead. So ancillary tests, there are only 3 ancillary tests which are described in American Association of Neurology. Only 3 ancillary tests are accepted to declare patient brain dead. They are 4-vessel cerebral angiography, radionucleoside SPECT scan, and transcranial Doppler. EEG, somatosensory evok potential, CT, MRI angiography are not acceptable in USA, and here at least somatosensory evok potentials are accepted. So there are false positives in these things, and there are false things. Who is the expert in this? How many tests have he to report before we can say that I am an expert in this and I am giving you the report like this? So these ethical issues have to be considered. A particular set of training has to be introduced. Then they can be called as they are certified for brain death declaration. So these are the things which have to be kept in mind in dealing with ethical issues of brainstem declaration and organ donation. So now that this particular patient has been declared dead by neurological criteria, next what? Organ donation or withdrawal of somatic support. Once you have said that the patient has died and declared dead by neurological criteria, you should not say it is life support. It is always a somatic support. So accommodation, how long you will accommodate. Timing of death. It is determination of second apnea test. Here we have already come across these things. Consent. Is the consent needed? It is definitely based on regional preferences. Many countries consent is not needed, but in India, brain death determination or declaration needs a consent because it is linked to organ donation. For doing your regular clinical examination of cranial nerves, you don't need any consent. But if you are doing an apnea test, yes, you need a consent. And as Gopal sir has said, it is linked to organ donation, but for declaration of doing an apnea test, definitely a consent is needed. That is what the TOTA Act says. In Spain, it is an opt-out system. What is an opt-out system? Opt-out system is that you should make an effort to say that I am not going to donate my organs. This is an opt-out system. That is the reason why when Ranganathan madam has shown that in Spain and USA, the organ donation rates are 50%. 50 per million. Ours is only 0.5 to 0.8 per million. So that is the reason why we are on the lower side. There it is an opt-out system. So by default you are an organ donor. So what is happening to the autonomy of the patient there? Is he given a choice? He has to make an effort to be out of it. So according to the ADA Act, they did not address the consent. That's what I said in the previous slide. The consent is not addressed in ADA Act, and the consent is not being taken from the patient per se because he is not enabled to give the patient. The consent is being taken from the next of the kin. So death by neurological criteria is equivalent to medical legal death, and that is the reason why they say how they are going to answer this particular question is, when you are doing death by cardiorespiratory failure, that means you are just going ahead and declaring him dead. So similarly, if death by neurological criteria is equivalent to death by cardiorespiratory failure, then you don't need a consent. But you are saying that for organ donation, again you need a consent. So these are the ethical dilemmas which we have to ponder upon and also discuss in many domains and come out with proper solutions. So families have to request for second opinion. What is happening? Can the families request for a second opinion? Your hospital has formulated a primary board and they have declared this patient is dead. Can they go for a second opinion from anywhere and independent confirmation from any other? So here the answer from TOTA is that you have a secondary board here. The secondary board can decide whether the patient is brain dead and go for brain dead declaration and organ donation if required. So independent secondary confirmation, transparency and truthful communication. Informed consent, this is what autonomy means. That means the person should with free will and his own voluntary status and with generosity he should donate his organs. Otherwise there should not be any involvement of coercion, greed or emotional pressure. So the presumed content, opt-out systems, there is a conflict of interest coming in the form of autonomy, and at the heart of organ transplantation lies the principles of autonomy and informed consent. So there is again an ethical dilemma over here. So after test refusals, as Sir has said, some after test refusals come. What to do in such cases? When you have a primary board, because now that as per TOTA Act you are going to declare brain dead as when you have a primary board. Primary board constitutes the 4 doctors. So once your primary board says that okay, he's brain dead, initially the next of the kin says I am going to donate organs, and later on they come with refusal. Then what? Then what? If you are not going to declare him brain dead, yes, you are going to put the time of death as cardiorespiratory death. But if you have already declared him brain dead, so then comes for your rescue the secondary board. You have to go to the secondary board, ask them this thing, and because the secondary board involves the governmental machinery, so ultimately you have to act as they say. So accommodation, there is no indefinite accommodation in cases of brain death, because if you are going to accommodate, you are going to do some unethical things in that. The needy, competing patients who require ICU services, they are not going to get it. So, and also you are going to give false hope of recovery to the family. This again puts a social doubt and confusion. So the societal confusion should be reduced as much as possible. That's why you can come up with finite goal accommodation where 24 to 48 hours say if the patient has some social families arriving or some religious consideration or pregnancy. This is important, dealing with refusals, and this is, you can always say that this is futile, not beneficial for anybody, and when they are not accepting, you can go to primary board or secondary board. So some special situations, pregnancy and patients on ECMO. So here, what is important is, in German study in 2010 in Heidelberg, the maternal physiological support for 30 cases has been done, and fetal survival rate has been found to be 63%. So here, there are so many ethical issues. How long can we provide maternal physiological support for brain dead mothers? Is it ethically right? Is the doctor permitted to withdraw somatic supports of the mother? Because some places like Ireland and Wales, where fetus is considered as a living thing. So here there is a lot of ethical dilemmas. So my question to you is, in these particular 2 cases is, in the act of self-defense, if a pregnant woman attacks you and in the act of self-defense you cause the death of her, are you going to be charged for murder of the fetus? Number 1. Number 2, if she is already an organ donor, if she has already agreed for organ donor by means of advance directive, and if during the cross-clamping of the aorta, if the fetus dies, can the doctor be charged for murder? So these are the questions, so many ethical issues and dilemmas which are still there. In patients of ECMO, we have to always remember that PaCO2 is functional membrane is there, so induced hypercarbia should be used or not is a question. Role of TCD, it becomes as ancillary testing becomes equivocal, and pre-oxidation is an issue in patients with ECMO. So there are so many religious perspectives in organ donation. Some religions say that integrity of the body should be preserved, and some religions say that brain organ donation and is a pious thing and should be done. In Hinduism, there is no definitive thing to prohibit organ donation, and all these things should be taken into consideration. So governmental policies and ethical dilemmas. So government should come with uniform policies so that all these ethical dilemmas are taken into consideration with discussions and wherever possible, and give finite solutions so that society also has the trust in treating doctors. So most of the not aware that it is equivalent to death by neurological criteria. Lack of communication is very, very glaring when there are a lot of issues with these so many ethical issues. As it is associated with organ donation, it always adds to complexities and expecting incentives and bill waiver. So you are doing so many tests like bronchoscopy and all after declaring brain death. Who is going to foot the bill for these patients? So that is also an issue. In summary, what I can say is brain death and organ donation are complex scenarios with many ethical issues, and uniform guidelines for testing, at least from the national level, to bring consensus, and government health policies should be done and should be part of training of postgraduates and specialty. Most of the people, as we have said in the previous study, most of the people don't know how to do brain death declaration and what are the ethical principles involved. And institutional policies should be framed. Every hospital should form a primary body and to look into these matters. And newer methods of training like simulation-based training and enhanced professional and public education should be there. Delinking of brainstem death or brain death and organ donation should be done, which is very, very important. And achieving self-sufficiency in organ donation and transplantation requires policies that can not only promote organ donation but also promote respect and ethics and all religious beliefs and ethical principles should be followed. Thank you.
I now request Mr. Maheshwar Reddy sir, Center Head of Kurnool Medicover Hospitals, to hand over a token of appreciation to Dr. Pradeep Reddy sir. I now request our next speaker, Ms. Delina, to come onto the stage, who is an experienced transplant coordinator who has handled countless donor and recipient processes. Her session on from brain death to transplantation will give us practical insights into coordination, consent, and surgical timing. We welcome you.
Good morning, respected doctors, guests, and my colleagues and my friends. This is me, Ms. Delina, Senior Transplant Coordinator in Medicor Hospital. I have been working with Dr. Kamal Kiran sir more than 15 years. My job is here to talk about how, as a transplant coordinator, we take over the process of converting the loss of life for somebody into a gift of life for several others. And how does it happen? Along with you, the critical care team and the medical teams who declare the brain death, actually look into the apnea test, CT, cerebral angio and other aspects, and maintain the cadaver transplantation. I will not be talking about the medical talks. I will be telling about the story as a transplant coordinator, how we take from the declaration of brain death after the brain death declaration, first declaration. Once apnea test has been done, what we do, we sit with them, with the family or attenders, to get acquainted with them, to win their trust, with mutual respect. We cannot throw the subject of organ donation. That is the very delicate matter for the family. So what we do, there is an international method that is called decoupling method. Decoupling method is nothing but we should not talk about the brain death and the organ donation at the same time. So these are the stages what we are facing at the time of, during the counseling time. First they denial, refuse to believe the death. The family members refuse to believe the death. And the next stage is the anger, but why this is happening, anger against the hospital, anger against the counselor or the security and the other hospital staff. Once brain death is declared, we should allow the diagnosis of brain death to sink into the family and also them to understand the irreversibility of the brain death. So the next stage is the acceptance. Finally, they come to a conclusion and they will ask for what is the next step and can we go for any other second opinion, they will ask. Then never request for organ donation during denial, anger or bargaining stage. Wait for the clear signs of acceptance from the family. During this time, we sit with During this time, what we will do, sit with the patient and attenders, support with the family to take a decision. It is very delicate time for the family, all those things, understand their emotions and allow them to settle down. Once the family willing for an organ donation, the next step is consent. Informed consent follows family willingness to donate. Legal forms must be signed by Legal forms must be signed by the proper next in. Documentation preserved permanently in medical records. There is a very important thing is the right form, right person, right time is the very important, and we need to. These are the some essential documentation. The form 6 and 7, nothing but the family consent. The next in. Form 7 is the consent with the minimum 2 of witness. Form 9 is brain death in case of minor if applicable. The medical documentation, Form 8 is the medical expert signature. Form C, brain death declaration form. There is 2 more documentation, and that is brain death declaration form and the donor parameters. Donor parameters should be filled by the recipient, filled by the transplant coordinator, and we have to send it to the Jivandan. And in case of MLC, we need to inform the forensic and the police as well as Form A, police intimation, Form B, forensic certificate and additional MLC documentation. After all retrieval of organs, brain death summary, MLC copy, consent forms, brain death certificate and other documents must be given to the forensic expert for his documentation. Then next step is the organ allocation process. We should inform to the Jivandan according to organs are allocated according to established regulatory protocols and waiting list criteria. Meanwhile, we have to maintain the donor maintenance that the critical time medical expert they will do. But we do as a transplant coordinator, coordinate with the ICU staff and the transplant teams, arrange specialized laboratory tests, and this time is the unpredictable time. Anything will happen. Next, we need to inform the Jivandan. The Jivandan is the governing authority, regulates the licensed hospitals, manages patient registration on waiting list, oversees organ allocation according to the established criteria, ensure ethical distribution of limited organ agent. What we do in the Jivandan coordination, follow the Jivandan instruction. Arrange and document allocation procedure, coordinator with the multiple recipient hospitals. These are the internal terms what we have to do. We have to coordinate with the neurosurgeons, intensivist, transplant surgeon team and other specialists, and we have to maintain the donor family and the other supportive department. Then meanwhile, the recipient, the suitable recipient, and family, they reach the hospital. We needed to coordinate with them. What is the clinical parts is the liver and kidney, whatever we are transplanting. We need to coordinate with the transplant team, blood bank, operating theatres, intensive care unit and laboratory and anesthesia department. What are the other supportive services, CSD, hospital nursing staff, especially financial counseling, transport services and food services, external condition coordination, Jivandan communication group, external physicians, other transplant centers and emergency service. Once recipient reach the hospital, evaluate the recipient medical suitability. We need to send some cross matching if the criteria, the first list, first patient or second patient, they are not suitable for the transplantation. We need to call the other recipient, the third recipient, evaluate the recipient medical suitability, coordinate with the surgical team, provide education to the recipient family, complete all pre-operative testing, obtain necessary clearance from the other department, prepare recipient physically and mentally, counsel regarding the transplant process, discuss potential complications and recovery, set realistic expectation of our outcome, and we should arrange a audio-video counseling with the transplant team and the recipient family itself. After all these consent and the family counseling, the donor shifted to operating theatre. Following Jivandan allocation instructions, the donor is transferred to the operating theatre with the utmost care and respect. We need to, at the same time, we need to coordinate with the other recipient hospitals. The final rise. After organ retrieval, the coordinator ensures donor's body is carefully and respectfully prepared, all incisions are properly closed and dressed, arrangement of transportation to home or funeral facility, expression of gratitude for the gift of donation. In short, the transplant coordinator. The transplant coordinator plays the key role in the transplantation, including live and deceased donor transplantation, lies between the donor hospital, recipient hospital and the government bodies, ensure time testing, documentation, organ retrieval preparation, and the final transplant to the transplant hospital by coordinating with the organ retrieval and the transplant team. So finally, we pledge to provide the bridge between the loss of life and the gift of life through organ donation. Thank you. All these headings here what we are. Thank you so much.
I now invite Mr. Swami Sir, Nizamabad Center Head of Medicover Hospitals, to please hand over a token of appreciation to ma'am. Once again, it's a privilege to welcome back Dr. Rahul Pandit Sir in this session. Sir will be focusing on DCD and its current status in organ donation. We welcome you, sir.
Thank you again. Can I have the slides, please? So, donation after cardiac death. a little different concept to what we have been discussing all morning. Now, historically, some of this may have been covered, but what death means to all of us is essentially when the spirit has left, or when there is an irreversibility which has basically been understood. And that we come to a consensus. The best example for that is we all do CPR in our patients in the hospital, right? Let's say for the sake of discussion, the CPR starts at 10 o'clock in the morning. 10 a.m., the cardiac arrest point went through. All of us started doing CPR on the patient. 20-30 minutes, all of us worked hard. And then at say 10:35, we all say that let's call this off. Very common scenario, right? In our hospital, we work hard for 20-30 minutes, we're not able to have ROS, we call it off. So what is the time of death? 10 a.m. or 10:35 a.m.? We all write it as 10:35 a.m., correct? We don't write it at 10 a.m. 10 a.m. the cardiac arrest actually happened. But we were not convinced. For a long time, 35 minutes we tried to be very sure that this process is reversible or not. Only when we all got convinced that this process is irreversible, we declared the patient dead. Correct? So that's what we do all the time. Whenever we have a complete understanding that to the best of our knowledge this process is irreversible, that is when we declare the death. For the poor family member who has been waiting anxiously at the corner of the ICU for last 35 minutes, there was still hope in those 35 minutes. But if you are a religious person, whatever religion you may come through, the soul has departed, the person has departed at 10 a.m. But we could only declare the patient clinically dead at 10:35 a.m. because we all were not convinced that this is what is happening. And I was just talking to Dr. Ghansham here, that couple of anecdotes, and I would like to share that because I think it's important that on a workshop you are aware that how to actually discuss about brain dead also, while the topic may not be what I am speaking. When we do a brain dead testing, all these clinical tests which have been discussed in the morning, we only test those functions of the brain which we don't, or those reflexes of the brain which we don't have to learn. We are born with those reflexes. So whenever I talk to the family members, I actually tell them that I am going to test these reflexes. These are the same reflexes with which we are born. We don't have to learn. Even a baby who is 1 minute old in this world will have a cough reflex, will breathe, will have a response to pain, will have a pupillary reflex. All those reflexes are basically there if they are a basic reflex. If a basic reflexes are not there, the person is dead. Then in the same sentence I go across and say that if you think that the heart is the ultimate proof of death, that the heart stops, the death happens. And let me just give you an example. In the 3rd or 4th week of pregnancy, a mother will have heartbeat coming up of the baby in the uterus. And around 8th or 9th week, I think the sonographic evidence can also be taken. But do we actually celebrate the birthday of the child on 8th week of pregnancy? No. We celebrate the birthday of the child when the child was born after 9 months, 8 months, whatever. What was the difference? Heart was still bleeding at 8th week, and you could have documented evidence of that. And the heart is now still beating when the baby is born. The difference is the baby is now breathing. The breathing was not there when the baby was not born. Mother was breathing for the baby. So breath is life. Hence apnea test is important. If you do not breathe, artificially the mother was giving us the breath. That's why all of us are in this world. If our mother was not there, none of us would be in this world. And the difference is that now the ventilator is doing the same job. Heart is beating, that's why. But the patient is not breathing. That's why it's irreversible. I think these two concepts, if you understand, you have to walk the journey from being patient will not recover from this to the acceptance of the family that the patient is dead. We as critical care specialists, neurologists, neurosurgeons, hospital administrators, physicians are extremely good in convincing people that this is a hopeless situation. Most families will accept it very quickly. After a couple of conversations done by the same doctors or the same group of individuals who are looking after the patient, they will accept it. But the acceptance from not being able to come out of this to death is what makes this process important. Now DCD, the tissue aspect of donation after circulatory death is actually very well established. So eye and skin donation have been going on for ages. And if you look at the two aspects of this donation, they are very well established across the world. People are coming forward to do netradan, eye donation, skin donations happen. People come home and collect skin and eyes. People go to the hospital and collect skin and eyes of patients. So it's an acceptable phenomenon. I think that's a plus in our side. The ball is in our court, how we actually utilize this already accepted phenomena of tissue donation after circulatory death to expand it to organ donation, right? So it's a viable organ, with a viable option to actually honor the wishes of the patient. If there are a lot of people who come to me and say we would like to donate organs, but the patient is not brain dead. At least happens 2 to 3 times in a year with me. I'm sure with all of you it would be happening as well. There is a special community in Mumbai, which is the Jain community. A lot of people from Jain community express this wish themselves that we would like to donate organs. Many a times we are not able to do it because they are not brain dead. So this is certainly an option for those who are willing to do it or those who may have already pledged their organs and the family is aware of it. Okay. So to define this, the Maastricht criteria, which is a place in Holland, in Netherlands, came out. What did the Maastricht declaration or Maastricht criteria say? That you could actually have 5 types of scenarios in which you could do a donation after a circulatory death has happened, after cardiac death has happened. The first is you have a patient who is dead on arrival. You could definitely take tissues, but you could also have, if the patient is still warm, you still feel that the death has just happened now, you could also do a quick retrieval of organs by taking the patient to theatre or by doing a normothermic reperfusion, which I'm going to elude a little bit on, and then we have a good talk on that as well coming up. Or you have a patient, which we just talked 4 or 5 minutes ago, unsuccessful resuscitation. We tried for 25-30 minutes, doesn't look like the patient is going to come back. You could possibly do that with the organ donation as well. Or you have an anticipated cardiac arrest, which is a control situation, which I have done, and I'm sure a lot of you who have worked abroad in countries where DCD is an established process, where withdrawal of life-sustaining therapy happens for futility, where you all conclude as doctors and nurses that any further care would not give this person quality of life or the person is unlikely to survive, and you actually pull out the machine, stop the inotropes, stop the ventilator, stop the dialysis, stop the ECMO, and let the cardiac death happen. That is more controlled situation, because you know when you withdrawn the care, and depending on how much support the patient is on, you could anticipate that the death could happen within 1 hour or half an hour or 45 minutes, and you could keep things ready, including the consent taken ante-mortem from the family that would you like to actually donate organs. The fourth scenario, which is the most likely scenario, which can happen in India and which we are legally fine to do, is cardiac arrest in a patient who is brain dead. So you've already finished 2 brain dead declarations. The consent is there. The organ donation consent is in place. You are waiting for the retrieval of organs to happen, but obviously all brain dead patients become unstable. And unfortunately, one brain dead patient goes into a cardiac arrest. In this patient, you should have no ethical or legal problems at all, because there's already a consent for donation. The brain dead declaration has happened. You can just take this patient simply to theatre and retrieve the organs very quickly. It would be absolutely fine. Okay? And the last would be an unexpected arrest in ICU. In a patient who is at a transplant center, you could do that. Now, why is DCD possible in India? Because if you look at this donation, if you look at this, the definition of deceased person by the Transplantation of Human Act of India, it very clearly says that you define a death or a deceased person in whom permanent disappearance of all evidence of life occurs by the reason of brainstem death, which has been discussed all morning, or in cardiopulmonary sense at any time after a live birth has taken place. So it actually defines cardiopulmonary death as well. So in my previous talk, there was a discussion about this not been mentioned in the Birth and Death Registry Act of India. This is only in the context of organ donation. But the second part of it is definitely a part of the Birth and Death Registry Act of India. And I was speaking to a Supreme Court judge around 2 years ago. And he said that you cannot interpret two different acts in two different contexts. They are all been passed by the same parliament, and if the judgment actually, that's why I said if you go to a court, you would actually win the case. That doesn't matter if it is in the context of organ donation, brain dead is still dead, and circulatory death is still dead. Okay. So with this, what is feasible in India? Category 4 is definitely feasible, which is a brainstem death patient with consent going in for a cardiac arrest. As Dr. Gopal alluded, that the first test usually confirms and establishes the diagnosis. The second is a confirmatory test, but as of now the Act says that you can only give a time of death after second test, so you should have 2 tests done in the patient with brain dead. And if we have a consent of the family, then it's fine. Now, can we do anti-water cannulations or not? I think that's I'm going to discuss it over the period of time. Okay. Now, category 3, which is a controlled donation, where you withdraw life-sustaining therapy in a patient for futility. How many of you in this room, now Ghanashyam I am sure has heard about it, how many of you in this room have heard about this landmark Supreme Court judgment came out in February 2023, which allows us to do a withdrawal of life-sustaining therapy? Anybody who can raise their hand? Just few hands have been there. So a lot of you are still not aware that you can actually withdraw life-sustaining therapy in India. Problem is this judgment needs to be adopted by the state. A lot of states have not adopted it. Okay. Now what does this Supreme Court judgment say? It says that you can withdraw care by using this pathway. What is the pathway? Pathway is simple. The first thing about the pathway is that either the doctor, the treating doctor, or a group of doctors identify that this is a futile state in which the patient is and the patient is unlikely to make a recovery. They raise the discussion with the family. Family also agrees that yeah, this looks like a futile condition. Then they raise it with the hospital and form the primary committee, which is a part of the hospital itself. Primary committee have got 3 members. The 3 members are, one is an expert in the problem in which the patient is admitted, so there should be a pulmonologist, for example, or a nephrologist, for example, or oncologist, for example. The other 2 members should be at least 5 years experience and should have reasonable experience in the said specialty. So intensivist comes out to be the most likely person to be a part of that committee. Within 48 hours, the primary committee actually examines the patient and comes up to a decision whether this condition is futile or not. If they all agree that this is futile, they talk to the family member. The family member also agrees, then they inform the hospital, then the hospital actually formulates the secondary committee. Secondary committee should have 2 more doctors from the hospital and 1 doctor who is nominated by the district health officer or the CMO or the additional director of health services, whatever is your health authority in your particular city. He could be from the same hospital, he could be from a different hospital. So again a 3-member committee is formed. Karnataka government has gone ahead and said that those who are empaneled to do brainstem death testing in your hospital, they can be a part of the secondary committee as a government nominee. So it essentially means that all 6 doctors, primary as well as secondary committee doctors, are from the same hospital. But all 6 have to be different doctors. You cannot have same doctors repeating from one committee to the other committee. The second committee also informs this, goes and examines. If they also agree with the primary committee's findings, they inform this to the family. Family agrees it. They inform to the hospital. Hospital has just informed the first-class judicial magistrate that this has happened. We have gone through the primary and secondary committee. There is no consent of the magistrate required. It is just an information to them, just a letter, information to them, sent formally by the hospital CEO or the medical director, informing them that. And then you can go across and withdraw life-sustaining therapy. It is actually a very good process because 6 doctors are involved, family consent is taken into that, and the hospital consent is mandated, and the judicial magistrate is informed about it. So it's a very robust process. Unfortunately, apart from Karnataka and partially by Maharashtra has allowed it to happen in government colleges. No other state has adopted it till date. And that's why not even one withdrawal of life-sustaining therapy has happened under this act. People might be withdrawing therapies. I don't know about a lot of people, but I am not able to do that in my hospital right now. But they might be withdrawing on the trust factors which they have with the family. They might be switching off the ventilators and doing things. Anyways, the time was right to think about donation after circulatory death. So we came out with this joint paper. We, a group of around 25 odd transplant physicians, intensivists, came across with this, and this was published in the Indian Journal of Critical Care Medicine as well as Indian Journal of Organ Transplantation as a joint position statement by us, and me and Dr. Mani and I think Kapil, 3-4 of us are a part of this paper from the IICCM. There are a few neurologists and there are a few surgeons, and there is of course the NOTO director also who is a part of it. And then this paper has been endorsed by these many societies. So we have a very robust paper right now which is accepted by a lot of professional societies that donation after cardiac death can happen. So as soon as the law is adopted, the judgment is adopted by the country, you will actually find that many states will be able to do this DCD immediately, controlled DCD. Now what documentation do we require? We have proposed that the same DNAR form which is there for the ICMR, you can use it. The Form 10, which is the Transplantation of Human Organ Act, which certifies brainstem death. If you have a category 4, you use the same thing. The consent for organ donation is a standard Form 8, which is standard across the country. You please use the same thing. And you sign a death certificate in case of circulatory death by using the Form 4, which is our standard medical death certificate, which we all issue in our hospital. Okay. Now, number of scenarios can be there, and this has all been there in the paper there. But the best scenario, I would still say, is a controlled DCD where you can withdraw life-sustaining therapy, or in a patient who is brainstem death. Uncontrolled cannot happen in India in a larger context because we are an opt-in country. Do you know what an opt-in country versus opt-out country is? Anybody who knows this? Opt-in versus opt-out? So countries in whom death on arrival, unanticipated cardiac arrest, unsuccessful resuscitation, they all can go for a, because in those countries the consent is presumed. Every citizen of that country is an organ donor unless they have opted themselves out. They have gone and said that we will not be an organ donor. Whereas in India, we have to opt ourselves in. We have to say that we would like to be an organ donor. Or the family says after the person has deceased that yes, we would like to donate the organs. So countries like Spain, which do 40-45 patients per donors per million population, is only possible because they 60 millimeters of mercury. Once it goes there, that's when the time the clock starts to tick, and if the death happens within 60 minutes of that, majority of the organs can be actually retrieved. So it's a very controlled environment. And I believe that we are moving there. If we don't address this today, in 5 years' time it will be knocking on our doors. So I think all of you need to be aware what what the DCD is and how do we actually practice that. Now, it is very essential to be a good communicator. You should be able to have an honest and open communication with the family. You should be non-judgmental. Do not judge their opinions. If they say no for organ donation, that's perfectly fine. You should not be non-judgmental about the fact that they may accept or not accept fertility. You should be compassionate. You need some training in documentation, in communication, in understanding this process, in the legality of it. You should be confident and should be able to successfully lead a team of doctors, because as an intensivist, it is primarily going to be your responsibility. And of course, you should be able to deal with different personalities which you would come across. There could be an aggrieved family member, there could be an accepted family member, there could be a family member who may not want to speak, or there could be a family member who might ask you 100 more questions about the same thing. So just follow the simple principles of communication. Prepare yourself when you are doing this meeting with the family. Usually try and do it in the room, not in the bedside, in the ICU or a corner of ICU, and have all the information about your patient. Talk to the person's family about all possible histories and the management options which have been given, what could have been done, and then make sure that you always ask what would have been the patient's wishes. We are going to run through these simple communication skills. I don't think it's a big thing to be actually talked about. Now, when I talk about DCD, and I've done this now twice in India, unfortunately, both the cases, the donation did not happen, but I have started talking about it with my patients now. And I have been involved in around, I think 18 or 20 DCDs when I was in Australia, but that was a long time ago. I've been in India since 2011 now. So around 15 years ago, I was doing DCDs. Around 15 or 18 happened in our unit in the 4 or 5 years preceding that. So I have been aware of how the process actually is done in a controlled way. Uncontrolled, we've never lost fortunately, touchwood, we've never lost a brainstem dead donor before the donation actually happened. So we've been actually good at managing a donor quite well. So the family has to understand the whole process. The judgment of the Supreme Court has to be talked to them. And then we have to also talk about organ donation in the sitting when the futility is understood. A good way, even if it is a brainstem death patient, a good way to start would be to think about eye donation. Eye donation somehow is accepted quite well. So just ask for eye donation initially and just leave it at that. Don't start talking about kidneys, liver, other organs. You'll always find that there is a bit of a pause and a hesitancy on the part of the family once you start talking about those things. So eye donation is the first thing you would ask. And then if they say yes, go out of the room, tell them thank you, go out of the room and say I will come and see you in some more time. Either arrange a meeting in an hour or two again, and then that is the time to talk about other organs and other tissues. So revisit the family once they are comfortable with eye donation as a concept. And this has worked with me quite well. Every time I ask for a donation, whether it is for a brainstem death or now for DCD when I am doing discussions, I start with eye donation. And eye donation somehow seems to actually hit the right pulse. On 50% of the times, they have actually asked, once they have said yes for eye donation, they have themselves asked that can other organs not be donated? And then that's the time you could also initiate a discussion immediately, or you could wait for some more time and revisit. It all depends on how the scenario is. No one recipe can be written up for that. So withdrawal of life-sustaining therapy, we've gone through this in detail. The team determines the futility. Primary and secondary medical board are done. If the withdrawal of life-sustaining therapy happens, then there is a discussion which goes across. The discussion essentially, once the secondary medical board does it, the hospital intimates the judicial magistrate, and the treating ICU team then refers to the transplant coordinator, as I said. And then once the consent for organ donation is taken, we usually withdraw the life-sustaining therapy. And before that, you could bring up a option of a normothermic reperfusion. I don't want to take out the thunder of the next talk because we've got a normothermic reperfusion talk going on after my talk here. What it does is, normothermic reperfusion does is, that once there is a motivation for organ donation and the family has consented for it, it is our duty to make sure that the best organs are given. We all know as soon as the heart stops, whether it stops for 1 minute or it stops for permanently, there is a decay of organs which starts immediately because of lack of oxygen. So normothermic reperfusion improves the availability of organs for transplant. So if you can do anti-mortem cannulations, it's like an ECMO. You just put in 2 femoral cannulas, one in the femoral artery, one in the femoral vein. Then as soon as the cardiac arrest happens, there is a 5 minutes of standstill. You do a ECG, you declare the patient dead, and then you could actually start a normothermic reperfusion through those cannulas. Of course, you will have to give some perioperative heparin, pre-death, pre-mortem heparin as well to make sure that blood doesn't clot. But that's the process. What I have been involved in the last few years of my stay in Australia was, we would actually keep the theatre ready. In 5 minutes time, we would spend at the bedside with the family, giving their last wishes and hugs to the patient, saying their goodbye. We would do a declaration of death, and then we would rush the patient to the operation theatre because it was just next door to my ICU. Some hospitals where the operation theatre and the ICU are at a significant distance, where it may take 5 minutes physically or 10 minutes physically for it to reach, they have also withdrawn care in the anesthesia room of the theatre complex. And the whole process which I was doing in ICU, they would do it there. So that's also a possibility to do that. So this no-touch time is very important, and then you start the cold flushes, the normothermic reperfusion, and that normothermic reperfusion allows you to have a reasonable amount of cold ischemia time preserved so that your organs are available for a perfusion. Where does the ECMO come into the picture? As I said, what normothermic reperfusion would require an ECMO. You have 2 minutes remaining. I'll be finishing there. Thank you. It is unfortunately only possible to have abdominal organs taken, and I will come up to this picture here. You actually need to put in a balloon to obstruct the flow going into the thoracic organs, because technically you should not be taking the heart, but a lot of
request everyone to kindly join back. We're going to move to the next session in another 2-3 minutes. now move into our third scientific session, focusing on organ-specific and transplant-related insights. Opening the session is an experienced and respected liver transplant physician, Dr. Ajay Shesharao Shule, Senior Consultant, Gastroenterologist and Hepatologist at Medicover Hospitals. Sir has vast experience managing complex liver diseases, and his expertise spans both medical and transplant hepatology. We welcome you, sir.
Good afternoon, everyone. Thank you for this warm welcome, and I would like to thank all the organizers for giving this opportunity. As this topic is rarely discussed among the routine conferences, so today I will be discussing briefly about the expanded criteria for donation in liver transplantation. So, all of us are aware that liver diseases are fastly being recognized as a public health priority in India. India contributed approximately 18% of the 2 million global liver-related deaths in 2015. Annually, India needs approximately 25 to 30,000 liver transplantations. However, the number of liver transplants being performed annually is less than 5,000. So there is a huge demand for organ transplantation which is not being met. So hence there is ever increasing demand for the cadaveric donation. So traditionally the ideal cadaveric donor is supposed to be less than 50 years with non-steatotic liver having normal liver function test. However, during this era where there is a pandemic of obesity and non-alcoholic fatty liver disease, it is difficult always to get an ideal donor for cadaveric liver transplantation. As there is high demand, the wait list is always increasing, which increases the risk of mortality being on the wait list. So there is a emerging need to expand the criteria for organ donation, leading to successful donation. So what are the expanded criteria? There is no such universal definition for expanded criteria for organ donation in liver transplantation. The donors which do not meet the standard criteria for donation are included in these criteria, having age usually more than 60 to 70 years, steatotic liver, that is fatty liver, donation after circulatory death, donation from hepatitis C virus positive donors as well as anti-HB core total positive donors, split and segmental grafts, donors with comorbidities and infections. So coming to the first criteria, donors with advanced age. In the previous era, it was not advisable to accept the donor whose age was more than 50 years, as there were more chances of graft-related dysfunction in the post-transplant period. However, in the last 2 decades, there has been successful improvement in the survival rate of these patients who received the cadaveric organ donation from the age more than 60 years as well as age more than 70 years. Singh et al. They have retrospectively analyzed and showed that the survival rate was approximately 84% in patients who received the donation from elderly grafts, and patients who received from octogenarian donors, that is in the 8th decade, in them also the survival rate was more than 80%. So what is if the elderly graft we are accepting, it should be having minimal steatosis, and the most important factor is that cold ischemia time should be less than 8 hours in these patients. In the previous era, it was not usually accepted, and there was a tendency to discard these organs because the overall cumulative survival in the patients receiving donation from elderly donors it was less compared to the patients who received the donation from patients with less than 50 years. However, when there was more study, it was found that there were certain confounding factors. If they were eliminated, the survival in the patients receiving donation after 60 or 70 years was found to be similar, compared to patients who received donation from the patients with less than 50 years. So these risk factors mostly included recipient age more than 60 years, recipient having ICU admission, previous multiple history of hospitalization, recipient MELD score more than 15, more than 20, cold ischemia time more than 8 hours. If these factors were eliminated, the survival was been found to be similar in both the groups. This is the same slide with extension. Now next criteria is steatotic grafts. The challenge in giving steatotic grafts is there might be dysfunction in the graft post-operatively. However, in the past 2 decades with advances in the management, including all medical, surgical and anesthetic managements, there has been improved survival in patients who received donation from steatotic livers as well. Steatosis is defined as microvesicular and macrovesicular steatosis. Microvesicular steatosis usually does not hamper in donation. However, if the steatosis is macrovesicular, we have to categorize it. Macrovesicular steatosis is categorized as mild if it is less than 33%, moderate if it is between 33 to 66%, and severe if it is more than 66%. So, when donation is being planned at that time, if we find that the organ looks to be steatotic, we have to do the liver biopsy, and at the same time we have to analyze if it is mild to moderate steatotic liver, we can accept that graft pertaining the recipient condition. So historically, it was there was tendency for discarding these such organs. However, if steatotic grafts more than 30% macrovesicular steatosis are there, the recipient, if the donation is from the healthy young donor, usually less than 55 years, and the cold ischemia time is less than 8 years, these organs can easily be accepted with good outcome in the post-transplant period, both short-term as well as long-term. Steatotic livers are not suitable for patients with fulminant liver failure and patients with prior history of abdominal surgery or prior history of transplant, as in these patients there might be a delay in explantation, so the cold ischemia time will be usually more than 8 hours. So there is chances that there will be graft dysfunction in the post-operative period. So the suitable ideal recipient for which steatotic livers can be given, they are patients should be having low MELD score, relatively young recipient, around 50 to 60 years. The post-transplant mortality in recipients who received steatotic livers versus non-steatotic livers. In the earlier era, compared in before 2011, there was survival in the patients, recipients who received the steatotic livers, it was less. The recipients who received donation from the non-steatotic livers. However, after 2011, the survival in both the groups was more or less similar, because there has been effective categorization of the recipient as and there has been effective donor risk recipient matching, so the survival rate has improved in the last decade. The next is donation from after circulatory death. This has been already told by multiple speakers in the previous session, although I will have a brief discussion on this. There are 2 routes for donation after circulatory deaths, controlled and uncontrolled. Usually what is recommended is to go through the controlled route. Challenges in accepting these grafts are that there is risk of increased warm ischemia time, which might lead to increased risk of primary non-function after transplantation, as well as development of ischemic cholangiopathy in the post-operative period, leading to graft necrosis and graft loss. However, if appropriate donor and recipient matching is done, these organs can be effectively taken with improved survival compared to the brain dead donation from the brain dead patients. United Kingdom DCD score has been developed which stratifies these into 3 risk groups, including the criteria like donor age, donor body mass index, functional donor warm ischemia time, cold storage, recipient age, recipient mail store, and retransplantation. Based on these 8 points, they have categorized them into 3 groups, which are low risk group, in which score is less than 5. In these patients, organ donation from the DCD grafts can be easily accepted with good survival after 1 year. It is around more than 95%. If the score is 5 to 10, then there is high risk. There is chances that patient might develop post-operative complications. So these grafts, they might need to be given some treatment before considering for them for transplantation. Like just in the last session, it was highlighted the recently coming thing, that normothermic perfusion technique, which has improved survival in these patients. And the next is futile group, in which the score is more than 10. Usually these DCD grafts, they are recommended not to be used unless until in certain exceptional criteria. So the ideally recommended DCD liver graft, the donor age should be less than 50 years, cold ischemia time should be less than 8 hours, and there should not be any significant macrovesicular steatosis. However, going beyond this, Indianapolis group, they have defined the extended criteria for using DCD grafts, which are any of the following: that is donor age more than 50 years, donor body mass index more than 35, donor functional warm ischemia more than 30 minutes, with donor liver macrovesicular steatosis more than 30%. They found that using extended criteria donor for DCD grafts compared to the normal recommended DCD grafts, the survival was similar in both the groups according to the Indianapolis group. Now next is grafts from the patient with hepatitis C virus infection. Previously, there was no effective treatment for hepatitis C virus infection. However, in the last decade, the treatment with the direct acting antiviral, it has revolutionized the HCV treatment. So there is complete cure with HCV. So nowadays, we can accept the grafts from patients with HCV infection. Woolley et al. They demonstrated effective use of HCV donors in heart and lung transplants with no HCV risk to the patient if they were given effective 24 to 28 weeks of treatment for HCV to the recipient. Similarly, Keating et al. Showed that HCV affected liver can be transplanted to the patient waiting for the liver transplantation, and if they have been given successful direct acting antiviral treatment in the post-transplant period, there was no risk for HCV infection. However, only one thing in these grafts is that there might be an increased risk of acute cellular rejection in patients receiving grafts from HCV positive donors. So the transplant physician and surgeon, they have to be little vigilant in order to prevent and minimize the risk of rejection. Split liver grafts. Traditionally, the split liver graft is that the one graft would be divided into the two equal parts or two different parts. Dividing segments, initially it was used that one portion will be given to a pediatric recipient and the other portion will be given to an adult recipient. In those times, usually segment 2 and 3 were given to the pediatric recipient and remaining was given to the adult. However, nowadays right lobe and left lobe, they can be separated differently and can be given to the adult recipients. So the split liver transplantation, it might be technically challenging. However, if it has been performed in expert hands, it has shown that there is similar survival in patients who are receiving split transplant compared to patients who received full organ transplant. This is ex vivo perfusion. It was discussed in detail in the last session. It is nothing but using normothermic machine perfusion. Previously it was used, cold storage was used. There might have been increased chances of ischemic damage to the liver during the cold storage. Now the normothermic machine perfusion, it is a novel technique which decreases the risk of ischemic damage to the graft. It also improves the graft quality, and we can objectively assess the graft function of the liver blood flow during that period, so that we can get sufficient time to improve the condition of the liver before giving it for the transplant. Lastly, livers that nobody wants. Because of multiple reasons, the graft liver, they are not accepted, maybe because of age and other risk factors. So in one study, they found that livers that nobody wants, at least 3 centers have denied the liver. So when they took these livers for grafting to the patients, they found that there have been equal, not less, survival in patients receiving these grafts compared to patients who received graft when they were declared in the first stage only. As there is shortage of organs, we should encourage to use these kind of organs when necessary. So now coming to the conclusion, as number of cirrhotic patients who are on wait list, they are increasing, there has been shortage of organs. So we need to expand the criteria so that the number of donations will be increased. So expanded donor criteria, they have significantly increased the donor pool. However, the acceptance, there is a little bit of risk, but it is justifiable. There are technological advances in using enhanced ECD viability. Certain ethical issues come because we have to counsel the patient that patient might be receiving a donation from a HCV positive patient. So we have to counsel the patient regarding that. There might be a risk of developing HCV in the future. Although there is a treatment available, patient has to accept that risk. So this should be clearly communicated to the patient that we are giving the patient organ from a HCV positive donor. Similarly, patients with getting donation from anti-HB core total positive donation, that is, the donor has history of HBV infection in the past, however the active infection is not there, although there is now currently good treatment available which can prevent HBV transmission in the post-transplant period. Lastly, ECD grafts, they are best suited for patients who are relatively stable with low MELD score, and for those whom the risk of waiting exceeds the potential complications using a marginal donor. Thank you. So I would like to take if any questions are there. Thank you. Thank you very much.
I now request Namrata ma'am, Center Head of Warangal Medicover Hospitals, to hand over a token of appreciation to Dr. Ajay sir. Thank you, ma'am. Our next speaker is someone who stands at the heart of renal transplant care at Medicover Hospitals, Dr. Arun Kumar Donokunda sir, Senior Consultant Nephrologist and Renal Transplant Physician, with years of clinical experience in managing patients with chronic kidney disease, dialysis and transplantation. Sir has been instrumental in guiding both pre- and post-transplant care for hundreds of patients. We welcome you, sir.
Good afternoon, everyone. To thank Society of Neurocritical refreshing. Sympathetic activity resulting in autonomic storm. This is the most important phase in the management of brain dead donors, because this is the phase where there will be intense vasoconstriction across all the organs. Diabetes insipidus, which I will be telling in coming slides, diuretics and vasodilatory shock, all these things tend to cause hypovolemia and causing kidney injury. So what should be our target for fluid management? Ultimately the target is to maximize the organ perfusion. So try to maintain a MAP at least above 60. Try to maintain the urine output at least between 1 to 3 ml per kg per hour. And also there is always a controversy whether to overhydrate a brain dead donor or whether we need to underhydrate it. So always there is a discrepancy between the transplant pulmonologist and also the nephrologist. There is always a debate between dry lung versus wet kidneys. Why this is? Because if you overhydrate him, there is a high chances that your lung is going to get injured and it might be rejected. So this is the reason. So the best approach would be try to maintain a CVP somewhere between 8 to 10 if you have decided to go with all the organs. Or else if you decided that already pre-evaluation, if you decided that the lungs are of no use, then you can go little bit high on the CVP and try to maintain beyond 10. So what are the preferred solutions? So again it's always isotonic fluids, either 0.9% NS or RL, but do remember if there is a background of hyperchloremic metabolic acidosis, then avoid NS. Sometimes even RL can be hypoosmolar, so in that situations you can use some pH neutral isoosmolar solutions like Plasma-Lite. And after stabilization, if you are dealing with cases like hypernatremia in brain dead donor, then go for 5D or half NS. Now coming to the role of colloids, sometimes we may rarely compelled to use the colloids. So we have two options, albumin and hydroxyethyl starch, but definitely it's always albumin. Don't go for hydroxyethyl starch because it can cause AKI, it can cause coagulopathy, and it leads to delayed graft function. And even role of blood products, I will not go too much into detail. And coming to electrolyte abnormalities in brain death, one is the most important thing is hypernatremia, which we routinely see in almost 80 to 90% of the brain death patients. It is the result of maybe a hyperosmolar therapy like 3% NaCl or giving mannitol causing osmotic diuresis can lead to hypernatremia, or it can be due to poorly controlled diabetes insipidus. These two situations can lead to hypernatremia in a brain dead donor. So what is the clinical significance is because many studies have shown that if your sodium is more than 155, it leads to hepatic and renal dysfunction and also cause graft loss after transplantation. So our sodium target should be somewhere between 130 to 150 and target the urine output between 0.5 to 3 ml per kg per hour. And even other electrolyte abnormalities can be seen like hypokalemia, hypophosphatemia, hypomagnesemia due to osmotic diuresis or diabetes insipidus. Do try to correct these electrolyte abnormalities. And now coming to the second thing, hemodynamic instability. How do you manage? First, try to correct the volume deficit. Only go for inotropes. Even after correcting the volume deficit, even if there is a still hemodynamic instability, then only go for inotropes. So there are multiple types of inotropes. So there will be a controversy with this statement dopamine, but when I have gone through the literature, it has many studies pertaining to the kidney. I am talking here to the kidney. Dopamine is not only an inotrope, but it has also additional beneficial effects. It has an immunomodulatory effect, it has an anti-inflammatory effect. The main reason is we are worried about dopamine because of its alpha receptor activity, but dopamine receptor activity has shown these additional benefits of immunomodulatory and anti-inflammatory. Yes, I do accept that that's an old concept. Dopamine will increase the kidney blood flow, but that theory is long gone. So, but it has these immunomodulatory effects, making it as a first line, especially when pertaining to the kidney protection. And coming to the second thing, vasopressin, it is the best second line because It acts as a vasopressor, it can act as a hormonal therapy, and it also can be used for diabetes insipidus therapy. So we all know there are 3 types of vasopressin receptors: V1A, which are present on the vascular smooth muscle, V2 receptors on the collecting duct, and V3 receptors on the pituitary gland. So mainly our inotrope vasopressin will act through V1A receptors, improves the vasodilatory shock. The main advantages is it reduces the need of catecholamines, but do remember, if you give vasopressin on higher doses, it can cause coronary, renal and splanchnic vasoconstriction. Now coming to norepinephrine, it should be used as a third line only if your dopamine infusions are going beyond 10 microgram per kg per minute. Why we are worried about norepinephrine is because of its significant alpha-adrenergic receptor activity, which can cause increased capillary permeability and organ damage. Now coming to the hormonal changes, as I mentioned earlier, during the autonomic storm there will be increased circulatory catecholamines. There will be pituitary dysfunction, especially posterior pituitary, leading to diabetes insipidus because of deficiency of vasopressin, which is nothing but ADH hormone. There will be marked decrease in levels of thyroid hormones and cortisol. Why this is important? Because these hormonal changes can affect the organ function. So it's always better to supplement these hormones because it can increase hemodynamic instability, it can improve hemodynamic instability, it will improve organ function and increases the likelihood for organ retrieval. Now coming to the pituitary dysfunction in brain death, why as a kidney point of view it is important? Because in brain death it is always the posterior pituitary dysfunction which is more common than anterior pituitary because of their peculiarity in their blood supply. Even after brain death, posterior pituitary is always compromised, anterior pituitary is relatively compromised. That's why posterior pituitary dysfunction is more common than anterior pituitary. So diabetes insipidus, as sir mentioned previously, diabetes insipidus has been reported in almost more than 80 to 90% of the cases in brain death. So again, these are the diagnostic criteria: urine output more than 4 ml per kg per hour, sodium should be more than 145, serum osmolality should be. So we have to be careful. Heparinization and mild hypothermia has been suggested that it can be nephroprotective. So what should be the criteria for kidney selection? These are whatever I am telling right now are mostly US based criteria, but it's not that we have to strictly follow these things. They will tell that we should have a normal kidney function, it is the creatinine clearance should be more than 80. They should have an acceptable urine analysis. Donor should not be a hypertensive, donor should not be a diabetes mellitus, but not strictly. Donor should not have any kind of malignancy apart from primary brain tumor or treated superficial skin cancer. There should not be having generalized viral or bacterial infections, and they should be negative for this assays. And these are the extended criteria donors. Even we can accept if the patient age is less than 6 years, or if the donor age is more than 60 years, or if the donor age is more than 50 years with any of the combination of these two of the following, like history of hypertension, serum creatinine being more than 1.5, the cerebrovascular cause of death. Still we can consider these donors, but do remember these have relatively worse long-term survival compared to the normal donors. So we have to monitor the kidney parameters. And sometimes we might have to do radiographic imaging of the kidneys during management, because if there is a family history of polycystic kidney disease, if the history of kidney stones for the brain dead donor, or there are any urological anomalies, we might have to do radiographic imaging. So always there arises a question: patient has received lot of contrast, can these kidneys be selected? Yes, we can select, but do remember, even if the patient is not brain dead and is going for any confirmatory contrast requirement diagnosis, then do adequately hydrate the patient and try to give N-acetylcysteine to decrease this impact of contrast nephropathy. Should we accept the kidneys from brain death donor if he is a diabetic? Again, a question of debate. Sometimes we can do a kidney biopsy and prognosticate whether this kidney can be donated or not. So yes, we have accepted sometimes even the patient with diabetes also, if their histology is very good, we have accepted the kidneys. Again, should we accept kidneys from a brain death with sepsis? Maybe if the donor has received pathogen specific antibiotic at least 48 hours prior to donation, we can go for these kidneys. If there is a meningitis, again the same rule applies. We have to give antibiotics at least for 48 hours prior to donation, and followed by after transplanting you need to give antibiotics at least for 5 to 10 days for the recipient. So how do you reduce the risk of transmission is by just depending on the nucleic acid test. So there is a provision that hepatitis B positive donors can be given for hepatitis B positive recipients, and hepatitis in the same way applies to the hepatitis C also. What are the absolute contraindications? It is patient having active malignancy, uncontrolled sepsis, and active viral infections like hepatitis A or HIV. Maybe these are the sometimes where we might have to reject the kidney. So what is the role of biopsy? Usually not routinely indicated, but sometimes when there is a diagnostic dilemma whether these kidneys are good or not, we can do kidney biopsy. I have done at least in 3 to 4 of cases in the past 5 years, and we have sent for histology, and we will assess this MAPI scoring, Maryland Aggregate Pathology Index. So it is based on 5 parameters: arteriolar hyalinosis, fibrosis, multiple things. So there will be a scoring system of coming around 15 points. So if anything, if the points are beyond 7, we need to reject the kidney. If it is less than 7, we can accept. So duration of brain death, does it impact kidney transplant outcomes? The answer is no. Recipients and also these patients will require a lot of immunosuppression, and there will be delayed graft function, and also these patients are more prone for infections after transplant. So these are the technical challenges as a nephrologist we will be facing after transplant. Thank you.
I now invite Shwankar sir, Center Head Medicover Oncology Institute, to hand over a token of appreciation to Arun sir. Thank you sir for your insightful presentation. We now welcome our next speaker, Dr. Krishna Gopal sir, Senior Consultant Gastroenterologist and Hepatologist. Sir brings with him extensive experience in managing complex liver conditions including cirrhosis, acute liver failure, and transplant-related hepatobiliary disorders. He is also widely known for his expertise in advanced endoscopic interventions, playing a crucial role in liver transplant evaluations and post-transplant care. Over to you, sir.
So my topic today is the continuation of the topic which was discussed by Dr. Ajay and Dr. Arun. I will be discussing the organ-specific issues related to the liver. So coming to the introduction, liver transplant is the only curative treatment we have as of now for the patient with end-stage liver disease. There is an increased prevalence and the incidence of the liver disease or cirrhosis requiring liver transplant globally. We are facing the shortage of cadaveric organ. There is a need of awareness for the liver donation or organ donation in India, and there are some specific organ related issues. So this chart, it shows how many different organ donations were happened during the prospective year. We can see there has been an increasing number of the organ because of the increasing prevalence of the obesity, or we are getting a very small liver. Accordingly, we have to justify giving it to our recipient. The donation from the brain dead donor or a cardiac arrest donor recipient, the increased risk of infection due to the immunosuppressive therapy, So all this need to be a protocol, screening and the management of the infection. What we do in our unit is we always send a culture for the for the prospective donor, and if during our theatre timing for the recipient, we tend to send the surveillance culture for the ascitic fluid, for urine, and if required a blood culture also. Liver transplant, if it goes well, the long-term success rate is 90 to 95%. After 5 years, the life expectancy is as good as the normal population, but they need a lifelong follow-up and an immunosuppression therapy. So coming to the take-home message, cadaveric liver transplant remains a vital solution for the patient with end-stage liver disease amid the shortage of the organs. Donor and organ-specific factors significantly affect the outcome of the liver. The ischemic injury, donor health, infection and preservation technique must be carefully managed, and they need to be evolved further. Ongoing evaluation of immunosuppression and preservation technique will improve the outcome further. We need to have more and more public awareness and the organ donor registration in India. So this is how our Telangana Jeevandan committee is there, which say that the loss of one life could be a beginning of so many other lives. Thank you.
Thank you, sir. I now request Dr. Raju, sir, HOD of Critical Care Medicine, Chandanagar Medical.
Myself speaking to lawyers, like-minded people, we can speak the same language and we have the same jokes and we can crack up when we talk about certain things the nuances of professional, those little things that lawyers are aware of. But when I'm speaking to doctors, I am a little cautious because you save lives. You give what is promised by the Constitution, which is good health, the right to be healthy. That is a promise that is given by a Constitution, and I think, when speaking to people of your caliber, I think, I have to be I'm very respectful, very, very mindful, and I hope I can give you some information that will help you in your professional journey. And this is a very, very important topic. I see a lot of confusion out there given the overlap of laws. Given that there is no clarity right now as to what is applicable. The previous law, the amended law, the TOTA has just been adopted by Telangana. There are multiple states which have adopted. Some states like Andhra haven't adopted this, the new TOTA as yet. So there are multiple layers in this topic, and I will try my level best to give you a practical legal insight. I also would like to thank Medicover. I really congratulate you. This is a very good initiative that you have. I believe law is something that should be spoken of in every field, because law is an underlying thread that ties every field. Our Constitution governs just about every field. So while whether medical education should have some education on law is a separate topic, but having that in conferences like these, I congratulate Medicover. With this, I would just like to proceed. We are all aware, you have been talking a lot about the regulatory framework and how the process of I'm sure you are aware of the process of registration of hospitals, etc. But let me start with saying, why is there a need to regulate the organ donation, or rather organ transplant, and now it's organ and tissues transplant, the whole need for having a legal framework around it. Why is it so important? We are evolving, as we are seeing, medical tourism is becoming extremely important. The ethical need for ethical transplantation, need for ethics in transplantation, in donation, these are essentials today, not only from a moral perspective, but even from a commercial perspective, if you want to take the medical field in India into the next level as a destination of medical tourism, as a very, very, preferred destination of medical tourism, one thing that is key is transparency. And therefore, the THOTA is actually trying to bring in transparency, trying to bring in the ethical aspect of ensuring that no common man is taken advantage of. At the same time, the right to health is given to everybody, what is guaranteed under the Constitution. And of course, this is a very, very important act to prevent illegal organ trafficking. So from that perspective, I am only talking about the practical legal aspects. I'm not going to go into the regulatory, if I start talking about the act, as I was just talking to someone from the legal team, it's going to take a long, long time if I have to really take you through every provision of the act and give you an understanding, which therefore I believe is important as a topic in itself for a full day workshop. So if I'm going to just try and condense that into for 20 minutes conversation, I will be doing injustice to that and injustice to you as well, because I will give you half-baked information. Therefore, my intention is to tell you what is it that you should look for and what is happening in the jurisprudence. How is the court looking at it? So court fills in the gaps that you don't understand in the statute. And that is what I'm trying to do today, to tell you the importance of judgments. Very recently, and I will go to the judgments, I'll quickly take you through a couple of slides which will give you, it'll be like a recap of the law, but then I will stress more on the judgments so that you understand the importance of seeing judgments to understand the intention of the act and how the act will fill in the gaps which are not being filled in because of the ever-changing pace of the medical field. So let's just understand the act. We all know these definitions, but just to recap for you, what is therapy? Before I go there, the THOTA Act, as we call it, the Transplantation of Human Organs and Tissues Act, what does that act, why was that act put in place? Please understand, as a litigation lawyer, when you see an act, what is important is to understand the objective of the act. If you understand the object of the act, it becomes very easy to be very careful about your actions. If your actions are aligning with the object of the act, then it is only about the procedure in the law. If your actions are not aligning with the object of the act, you are doing something that is absolutely not right, and therefore you should stop right there. The object of this act is an act to provide for the regulation of removal, storage and transplantation of human organs and tissues for therapeutic purpose and for the prevention of commercial dealings in human organs and tissues, and for matters connected therewith or incidental thereto. Now see how broad this act is, the object of this act is. It is not only for transplantation. So what happens the moment you say THOTA Act? What does your mind go to? It goes to transplantation. But what this act is actually doing is, it is the regulation of removal, storage. Storage is something which is highly overlooked. So storage and then transplantation. And it now includes organs and tissues, and then only for the purposes which are therapeutic purposes. So what is the purpose of the act? Therapeutic purposes. For that, transplantation, storage and removal. In the wrong order that I'm telling you, the right order is removal, storage and transplantation. So what is therapeutic purposes? It is, as defined, means systematic treatment of any disease or the measures to improve health according to any particular method or modality. And mind you, this is also, the object is not just limited to this, it is also connected for matters connected with it or incidental thereto. So anything that can be connected with it or incidental thereto will fall within the domain of this act. Now these definitions are some of the important definitions. There are more, multiple definitions. The reason why I'm showing you this is to explain to you why the definitions are very important. You have to read the definitions with the object of the Act, and then you will come to the right understanding that what is it that the Act wants you to do, what is the intention. Now, I'll pause here for a minute and mention that there is a little bit of lack of clarity in law right now. We are at a stage where Telangana has recently adopted this Act, but there is still lack of clarity with what will apply where. And I think it's a very interesting phase because you have to be very, very creative. You have to ensure that you are in compliance with this Act because this is the legislative intent. You know the legislative intent may not be the same procedure because you are not, this Act has not been, the rules have still not come, it has still not been notified possibly the way it has to be, the repealing of the previous Act is still not done. Many legal loopholes are there, but that does not mean that you disregard this Act. Understand what is the ask of this Act and then implement it accordingly in consonance with the current prevailing Act because this is the future. Therefore, these sort of things are what you should look at when you are actually trying to understand whether you're on the right side of the law or not. And always remember, you must always err on the right side of law by way of abundant caution. Moving on. Now these are since the topic I was given was do's and don'ts, before I go into the judgments and before I talk in detail about, what is going to come in time with the TOTA Act, how are the courts looking at it, before I move in there, please bear in mind that the removal of organs and now tissues as well is only for therapeutic purposes. So that is where the definition becomes very important. Now just see how broad the definition is. I'll go back to the previous slide if you see the previous slide, it says therapeutic purpose means systematic treatment of any disease or the measures to improve health. It does not necessarily say treat health. Right? So the word or is there. This is how we have to look at it when the cases come up. What is the objective of your removal of the organ? Now what is the right under the Constitution? It is right to health. Now, if this is being done for treatment, is it being done for betterment of health? These are all very broad terms, and these are the kind of areas which the judgments fill up. So you might have someone who may come up to you and who may be of good health, but through certain, and these are true times that are going to come, because today you have all sorts of tests which are preventive in nature. So those tests may indicate that going forward, if this person consumes this, there may be an impact on the person's kidney in a certain manner. And these are possible scenarios. I don't know medically, this is why I said it's a little bit of a challenging conversation to have with actual doctors who practice this. They may say this girl is talking of a hypothesis which may not happen. However, as lawyers, we don't rule anything out. So tomorrow, if there is a set of circumstances where, it is possible that someone has been informed in some manner of a possible transplantation that may help in bettering the health, then will that come under this? So is it a therapeutic purpose? Questions like these may arise, and therefore we have to be very, very cautious. Now, of course, my talk today is limited to brain death. I will come to that. That is also a part of, the larger subset of this Act. But just wanted to tell you from a practical perspective how you should read this Act and how broad the contours are, and therefore the importance of precedents which are happening on a regular basis. Now, some of the other things, of course, these are procedural in nature. Anybody who's familiar with the Act already knows this. You need a consent, and the consent has to be without coercion. Of course, the whole idea is of the Act is to stop or or make zero the happenings related to illegal organ trade, and therefore the safeguards, these are all safeguards that have been built up. One is authorization in writing by the donor while he is alive. What happens if there is an authorization after he dies or she dies? How do you go about it when there is no authorization? Then whose consent matters? What if it is an unclaimed body? How will you get the, what are your rights with respect to an unclaimed body? And in fact, let me tell you, I'll just step back talking about definitions. Hospitals also includes educational institutions. So these are the broad things, that this act has to be looked at. This act is not a one-size-fits-all. Many circumstances arise and which are not clear herein, and therefore we have to go to the court, and all the time coming out judgments which are newer and newer judgments are coming out as we talk as well. Then how do you look at situations and how do you interpret? That becomes a key cornerstone of the legal aspects of this act. Moving on, near relative. You will see a term near relative coming again and again. Who is a near relative? That is very clearly defined in the act. But what happens if there is no relative or no near relative? How do you deal with a situation like that? There are cases where ex-wife has also filed a case, has given an objection when the donor decided to donate his organs. And what happened in such a situation, I will show you that as well. That matter went to court, and then the court gave its ruling and said that, the spouse may have a very, and there are two cases, one is ex and one is a present spouse. The spouse may have a very limited role. So I'll quickly jump through these, the definitions, etc. in the Act. I'm not going to talk too much about that now and take you directly to the judgments. Just one thing I want to mention, the importance of the procedures. In law, as long as you have followed due process, you are not wrong. It is when you don't follow due process, and you don't just follow due process on paper, you follow it in spirit and in essence, and in the manner in which it is recorded. So you have to be absolutely clear in spirit and in law that you have done everything to the T, which is why the object of the act becomes very important. So you must align with the object, you must be mindful of the procedure as given in the act, and your intention becomes very important. Are you just is it just a tick box compliance? Is it truly compliance both in letter and in spirit? So please ensure that whenever you are doing whatever, any transplantation, any removal is done in accordance with the procedure. Where is the authorization committee? Do you have to go to the authorization committee? There are cases where hospitals have said, no, you have to come to us and we will go to the authorization committee, which is not correct. There are judgments now which are as recent as last year, where it has been clearly said that you can approach both donor and recipient have to sign before the authorized committee. So things like these are evolving for the purpose of curtailing, which is the object of the act, curtailing illegal organ transplant, into making sure there is transparency, and all this will overall boost the medical profession, confidence in medical profession, and also make this destination, India, and in particular the states, a very, very preferred destination for medical tourism as well. Now moving on, penalties you are all aware of. There are strict penal penalties. So I will not just call it penalties. Penalties are of course the monetary aspect, but also imprisonment, etc. So you have to be very careful. Now just see these few judgments. I'm not going to delve in too much, but quickly. there was in between a big conversation that there was a domicile requirement for you to be, for someone to be able to get an organ. This has actually been undone by the Honorable Supreme Court, and given that this is the right to health is something that is guaranteed internationally in the many charter documents, and also in our constitution, right to life ties in with right to health, and therefore, you know, the domicile requirement was struck off. The Gujarat law requiring domicile was also struck down. Moving on, this is also about, you know, another case where this is where the estranged spouse had objected to the donation of the transplant, and the spouse, that was also struck down. It was said that the donor has absolute right. Now I'll quickly take you through a couple and close. This is also now consent for donor, the second case that I was talking about in the lifetime, and this is a current spouse, not an estranged spouse. This was also struck down, stating that the donor has full right to make his or her own decision. And lastly, this is a case in Chennai, in Tamil Nadu, where if there is no commercial objective involved in a transplantation removal and donation, then merely based on affection and sincerity and you know, there being love and affection with...
At least for 24 hours. That's what we have been following, and that's what when I checked with Dr. Subba Reddy at Apollo, I think that's what almost all the hospitals in Telangana are kind of practicing. And that's the kind of, probably, you know, to kind of have that kind of a buffer period to avoid these kind of discussions. So 24 hours, it will not everything, right?
Yeah, I agree with you, sir, that in 24 to 48 hours, the confounders, we have to deal with it. So, the next question about the financial aid to the donors. Should the hospital give financial aid to the donors?
Regarding this one, see, a lot of opinions and comments are there. There are few centers, states where government is encouraging. Government itself is offering 5 lakh per donation to increase the organ donations. See, if it is a definitive ideal candidate for, brain dead candidate who is fit for donation, but a lot of people may not come forward. In such, few states, in India also, their government itself is promoting this. So, but if it is, it should not go off the line.
So in life related, I would let Madam talk, because there it's actually a crime to give. Okay. Now in brainstem death again, it's a donation, right? Ideally there should be no exchange of any benefit or anything to the donor family. What government has done, and some of the states have adopted, is given the liberty to stop the billing once the consent for organ donation happens for that person, which I think is a reasonable thing. If they have consented for organ donation, from that point of view, you stop the billing. Up until that, they pay the bill.
importance of what the courts have held in the past becomes very, very critical. You know, and I completely agree with you. At that point, take the help of your legal department if you have one, or take from your lawyers. But understand how the courts have looked at it. In fact, even in the case that I just showed you, a spouse's dissent was disregarded. So, you know, these are very tricky. This is tricky territory.
With no proven residual lesion at the time of donation. These we can consider.
So there is a very nice paper by American Academy of Transplant Surgeons, which actually talks about almost full with 90% non-accepted, except for a few of these exceptions which he said. But again, just like I was saying that for my piece I would not go into a confronting mode, most surgeons and physicians will not accept organ from a person who has an active malignancy. I would like to bring it to the notice about one case which happened in Maharashtra a long time ago, which I don't know whether you are aware or not. But there was a patient who had GBS, Guillain-Barré syndrome, became brain dead because of hypoxia. The family consented for organ donation, and the kidney was donated just. And the patient who received it got GBS after 6 months. And GBS is a paralyzing thing which basically is non-infectious but can have a preponderance with infection, a Campylobacter jejuni infection beforehand. But anyways, this is what happened. And they were trying to sort of join the dots together and say that this is what happened. I think it did not go to the court, it reached to some settlement. But this is the fear, that if in 6 months' time somebody has an obscure tumor of some other organ, how are you going to justify that you actually took it from somebody? And you would be left liable to answer that.
Additionally, what we follow is that someone, if there is a history of malignancy, we would prefer that the duration should be at least more than 3 to 5 years. And that cadaveric, that person should have received the treatment for that. If it is more than 5 years, then we'll accept, it is better to accept. But if it is, duration is less, then most of the transplant community people, they will not accept it.
Arun is not here. Arun was sorry. I hope Jelena, you will be able to kind of get this, or one of the panelists. See, one of the common things we see, Rahul, is a patient who is brainstem death is is an unstable guy. It doesn't take much time for his physiological parameters to get deranged. He may have an absolutely normal creatinine admission, but we have seen this very commonly, that his creatinine jumps within 24 hours, 48 hours to say go beyond 1.52. Now, would you? I was hopeful that Arun would have answered this. Would nephrologists be willing to accept a kidney where the creatinine is above normal, and this is because of the acute kidney injury? It's not a known chronic kidney disease, but because of the physiological derangement that happened post brainstem dysfunction, his creatinine has jumped. So can that be considered as a potential,
the correct person, but basically we will consider the baseline creatinine. If it is dropping to the above or more than 1.2, we will do a biopsy. After biopsy, we will come to a conclusion that it is suitable.
So what is the protocol to this?
Protocol again, most nephrologists will be happy to accept a modest rise in creatinine. I don't know the modest number, but if the creatinine was just 0.6, 0.7, and because of diabetes insipidus, hypovolemia, hypotension, contrast-induced nephropathy, if the creatinine has gone up, some modest rise, say 1.5, 1.6, will be accepted without a lot of discussion. But if the creatinine is 3, 2.5, 3, then there has been discussions in past, and I know there has been thought process of actually putting 2 kidneys in the same donor. So giving the benefit of doubt. That has also been, same recipient, sorry. That has also been thought about. So I think we have to, again, this goes on to the expanded donor pool. These are all borderline donors, and if you actually think of it logically, that 3 days ago the creat was 0.3, 0.6, and there hasn't been a lot of contrast-induced nephropathy as the issue. It looks like more of a brainstem death complications. then putting 2 kidneys to the same recipient would work perfectly fine. You would actually have a better outcome with that. So rather than rejecting it outrightly, say somebody who is going to dialysis every day and gets an opportunity to do this, a lot of recipients are willing if the nephrologist is able to think out of the box. And there are people who are doing this now.
Maybe other factors. Maybe I think considering the other factors like donor CAs, other lack of other comorbid conditions and baseline creatinine, all those things also we can keep in mind.
Extend the same question to the liver parameters. Your liver transplant surgeon, liver transplant nephrologist here. Suppose you have some sort of hemodynamic instability is causing ischemic hepatitis with
fatty liver or something.
Raised liver enzymes. Would you be happy to take such a liver?
Depends on what are the members exactly. So just as I discussed in the expanded criteria for donation. So ideal donor is with normal liver histology, normal no steatosis and normal liver function test. But most of the times we cannot get the ideal donor. So little bit increased enzymes, fatty liver, steatotic liver, say stage 2, that is steatosis more than 33%. If we select the recipient accordingly with recipient age less than 50 years with low MELD score and no comorbidities and no history of any multiple hospitalizations recently, then we can accept this graft. Although it comes under expanded criteria for donation.
Liver, I think, has got so much more because it's one of the best organs to regenerate. So I think hepatologists are actually, I feel so, I may be wrong, that they are more generous than the nephrologists. So they are able to accept more expanded criteria. This is serious medical stuff. We all know that liver somehow tends to be a little bit more protective than kidney. And they also have, if they have a very good healthy kidney, they also sometimes do a split graft and benefit 2 children, for example. That's also possible. So rather than 1 kidney going to 1 adult who is 60 years old, they may put one liver going to 1 adult, they may put 1 liver into 2 small children who are 15, 16, 20 years old and who have a long life to live.
Liver, how rapidly our enzymes are going up, number one. As I said again, say patients CAs, comorbids, we do consider. Third is obviously if the enzymes are going, shooting up with the patient, deterioration clinical condition of the patient, then still even then we do consider checking the liver on table. If required, we'll do send the biopsy also. And with the invention of all these machine perfusion and all,
one-sided, say, thalamocapsular bleed or something, having unconsciousness and one hemiplegia, they recover after a few months. So can this happen with a brain stem hemorrhage? Recovery can...
Your question is that anterior circulation hemorrhage patients recover, posterior circulation hemorrhage patients who are declared brain dead, is there a possibility of recovery? Is that a question, sir?
Yes.
Okay. So there is, if it is done in the, again I am borrowing words from madam, in the true essence, true spirit and the legal way of documenting brainstem death, which is ruling out the confounders, making sure that there are no other mimics which are there, do the proper testing by the panel of experts. There has been not one single case which has come back to life after being declared brain dead in the world. Whatever cases we hear about, I think somebody showed a case about a lady who was transferred from one state to other state. There has always been a breach in the process. And that breach in the process, basically trying to do a shortcut, sometimes, what Dr. Ghanshyam was saying, trying to hurry the case. As soon as the patient comes to you, you try to diagnose dead. All these things people have learned from experience. So if you do it in a true, right, absolute way of doing it, there is absolutely not a single case documented in PubMed literature. In tabloids, I don't know.
Second question. So, there is a very high risk surgery, including a death on table. Say, patient with acute myocardial infarction has got ventricular septal defect or free wall rupture or something very critical. He may expire on death on table. So this is explained to the family. So in that case, can we take, in case he expires, we can harvest the organs.
So this is Maastricht category 4 and category 3 and category 5. So there is a provision in medical literature to do it, but in the Indian law right now, while the law does actually say that deceased person, by means of which all cardiorespiratory efforts have gone after a live birth has taken place, technically you could do that. But here the patient is a myocardial infarction patient. Idea should not be that we want to immediately take out the organs after doing this. It would be ethically and morally very disturbing for me to take such a consent. Even if tomorrow everybody says that it's going to be a deceased person, still you do it. I think morally and ethically I would refrain from even talking about it, because then I don't want even 0.5% of my mind to think that my efforts would go down a little bit to not save this person and think about the organs which might yield out of that. I don't think I would be comfortable about it. Madam can tell the legal format of it if at all that is permissible. But morally and ethically I would be very, very worried.
So can I get your question again?
The question was, what he is asking is, let's say there is a patient who has come with a bad heart attack, severe heart attack, and you are attempting to do a angioplasty. Let's take that example. With a known thing that this patient may just die while doing the procedure. So the gentleman is asking that can we not take a consent from the family beforehand that if he dies we will take the organs.
See, the thing is, firstly, I'll just go back to the first question that we had, number of hours, etc. See, in the Act, it is very well defined. Brainstem death is very well defined. When a person dies, etc., what do you consider as a brainstem death is also very clearly defined. So, understanding when that situation arises is very clear. Now, the question of consent, also there is a process. If you rush it, now this is a very, very grey area. This is a very hypothetical, high-level kind of premise that has been given. Now, what if you have taken the consent and someone can argue that after taking consent, there was some interest involved and therefore you did not give adequate care? Right? Now, once the consent has come beforehand from the family members, you see, consent from family members is only when the person has not given consent in his lifetime or her lifetime. And then all sorts of premises can be built up. Now, if there is someone else, maybe, now I don't know if the person is married, not married, children are there. There are many other things that you look at. Who gave the consent? Was it given you have parents, you have spouse, you have children. Did you take from all? Was it absolutely? And then there is a process. There's a board that has to see under certain circumstances, right? It has to be...
Organ donation.
Okay.
In the patient, what we call as the DCD, donation after circulatory death. But still, this is exactly what I said, that morally, ethically, my primary duty is to save that life. I should not have even 1% thought in my mind that the organ maybe, or somebody should not ask me that your efforts were less because you were wanting to have the organs.
That is what...
So I would not even think of taking forget about organ donation. Consent also I would not even think of it. I would not think of organ donation as the outcome. What would happen is that if this person while doing this became hypotensive, had a cardiac arrest, had a CPR for a long time, and then became anoxic brain injury, and over the next 2 to 3 days in ICU was declared brain dead, then I would be comfortable to think about organ donation in that person. But not immediately while saving death on table, I would not be comfortable at all. Because our duty of care is towards that patient who is under our care, not for those 7 or 8 patients who may benefit from our care.
In fact, my question to you, sir, then would be coming from this. Duty of care and law, what takes precedence, or your knowing that,
So duty of care is for the patient and the patient's interest only. And if the patient's interest, that particular patient's interest demands that I do something which is ethically and legally and morally correct, I should be putting up my foot to whatever extent I can to help that patient. That doesn't mean that I break the law at any instance. But at the same time, I would be not willing to cross the boundary of the law for something like this, for example, where somebody else may get benefit. This is also come up, madam, quite regularly in directed donations. So I have had people say that we will only donate the patient's organs, but brain dead patient's organs, if my uncle's brother who is on dialysis. You have that question? So I don't want to steal the thunder from your question. So there has been a directed donation request as well. Again, directed donation according to me is morally not correct. But I think I may be wrong. There is some precedence there that directed donation was considered and there was an appeal in the court. I am not aware of what the judgment is. Again, I consider myself on the donor side. I am very clear when I talk to my family members of the patients, and while my hospital is a transplant hospital, if there is a brain dead patient in the hospital, I am always on the donor side. I keep my rest of the team members in the transplant ICU who and look after the recipients until the donor is sent home and final rites are done. I do not interfere in the transplant program at all. I have kept myself that way aloof. I am at the privilege to have 3-4 senior consultants who can look after in my absence for the transplant patients. And that makes my decision making very easy. I am on the donor's side. So whatever is in the donor's benefit, I do it. That includes time for handing over the body, what we were discussing before. So if there is a request from the donor family that we want the body in 15 hours, 20 hours, I put my foot down and say, no, this person has gone out of the way to donate. We have to make sure that their comfort level is taken into care.
That's a very good line to take, donor's side. That way you never go wrong.
Some more doubts? Kuch doubts have? Please go ahead. I mean, agar hai to please go ahead.
Devices come up, Neuralink. Say a decade ago, if somebody was quadriplegic, then we would have said medically, okay, we don't give any hope. Now, is it possible that some device may come up?
Elon Musk's Neuralink, which was recently.
Now devices come up by way of thought and a mind and a computer interface. Patient is able to write, is able to play chess. So
this is regarding the recent update. Elon Musk's Neuralink, where one of the patients who could not use his body, but I think that patient was not brain dead. The patient was
totally.
Brain is still working.
Yes, he was able to think.
Brain was still working, but because of the severe muscular involvement, he was not able to do, and he was quadriplegic. So after they placed the Neuralink, he was able to interact the computer and put his thoughts into action.
This is, I think,
50 years ago was happening. Everything else was good, lungs were bad, but there were no ventilators. Now we have ventilators and we don't give up on patients who have bad lungs. We treat them, we transplant them, we do proning, we do all sorts of ventilation. So I think it's progression of medicine, sir. I am sure in 10 years, 15 years time, there will be things which you would have not thought before. 20 years ago, when iPhone came in, nobody thought it would be all be moving with the camera in our pocket. Now we do
What you want to ask is there, do you see a possible future that you might have something like this for a brain dead patient?
No, sir. At this moment, as of now, see, the Neuralink, whatever is there for not brain dead people. Brain dead is different, totally. Then only we can go for organ donation. It's totally different.
Death criteria. Only after we have declared the patient brain dead, family has accepted it, organ donation consent has been taken, are the surgeon and the transplant physicians involved into that. So, death is death. As of legal definition right now, death is death, it doesn't change. And as long as you do it in the right way, I don't think any neural technology which will come will make a person live again, unless we are starting to believe in the mythology that it will come back where you'll be able to resurrect people from death again. That's a different discussion, philosophical discussion to have.
So many RTAs coming in the hospital can be potential donors, and how we safeguard about the medical legal issues related to that.
Madam, again, whichever patient walks through our door or is brought through our door, our primary intention should be to save the life for this patient. But you are right, many of these have catastrophic brain injuries and could be potential donors. So while our efforts go into that, there is a simple mnemonic which you can use, GIV, which sort of again resonates with organ donation as well. So Glasgow Coma scale of less than 5, intubated, ventilated, and absent or abnormal eye signs. That is what GIV is. And if you have any of these patients, these people are potential possible donors in the future if they don't recover. So a lot of them will recover, but initial GCS is never a right GCS to go by.
I think the question was, a lot of medical legal issues happen, right? So, getting the post-mortem or those things, I mean, how important are they in day-to-day life? Because these are some things, people, I mean, many of us have this mindset or the doubt that if it's a medical legal case, then probably he may not be an organ donor, or we may not proceed with brainstem declaration.
You have any donor coordinator here from your hospital? Madam, you will be able to answer that question very well. 90% of our donor coordinators actually look into that. They are very, very efficient.
95% of organ donation happen only in the RTA only. So in case of MLC, the hospital should register the MLC, and after that, when it comes to organ donation, after the consent of family, we will inform to the forensic and police. Then police and forensic surgeon, they will come to the hospital, and police panchanama and the brain death declaration and form C, whatever it is, so they will conclude the conclusion, and post-mortem will be done in the hospital before shifting the order.
So the idea is, I just want to clarify that having a MLC is not a contraindication or a hindrance for organ donation. So that is the message that we want to give. Right? There is a well-defined process, there is a well-defined legal way that even in those patients who have met with bad road traffic accidents with medical legal cases, if the family is willing and if the patient fits into the criteria of brainstem death, you can proceed with organ donation. So that's the message that we want to give.
If it is done in the hospital, that is so much better in Telangana. We are struggling in Maharashtra to get the postmortem done in the hospital, and it is very heart-wrenching to see after donation we have to send the body for postmortem in the mortuary. It is very heart-wrenching, and I don't know why it's not happening across the country. And I must applaud it. Telangana is doing it in the hospital. That's a very, very positive step forward for the family. They are just completely broken when they are taken to the postmortem rooms for postmortems.
Brain death, whole brain death or brainstem death? Brainstem death is considered as the whole brain death.
So I think this was covered by our neurologist, the talk in the morning. India follows the brainstem death. So if you are in Rome, be a Roman. If you are in India, be an Indian. Let's follow our law. Let's not try and overchange onto the other thing, because there has been no real problem with the current way in which we are declaring brain dead. If there have been problems, then of course that law needs to be looked at. But I would say everything in medicine evolves at some stage. And if there are new findings which come up in the light of the information, we may have to think of whole brain death or a brain dead. But right now, we have to follow our law. Having said that, the brain dead project, which was sort of the paper which came out, discussed this into great detail as well. And they had no official, so this was a group of neurologists, neurosurgeons and intensivists across the world, across around 60-70 countries who discussed this. And there was no consensus whether one is better than another, because ultimately I think they both lead to each other anyways.
Just one last question that I sorry, please go ahead.
One thing is, see, when there is this related to living donor issues, when there is no donor in the family and we are trying to do unrelated donation, it's a lot of time taking. So many, we need to get from police, police approval, and sometimes. Of course, I do agree with prevent organ trafficking, all these things. But in this current era of digitalization, all these things, if the patients are too sick, is there any way to speed up these things? And one thing why I am asking part to this one means, because of delay in the process, by the time we get the approvals, we may lose the patient. So we are not able to promote this unrelated donation in India, though they are real unrelated volunteer, though they are really, ethical and conservative kind of thing. Even then, we are not able to promote or we are not able to encourage the donations. Is there any way we have?
Yes, there is no set, there is no one size fits all, but I think on a case-to-case basis, given that once you will have to go through the process, but you can definitely speed up the process through courts. You can file a writ, you can do many other things where, you approach the court asking for the procedure to be cut down, and to be expedited. But it all will depend on the bona fide of the parties. If you can establish to the court that there is an urgency, there is the donation that is being done in accordance with the principles of law. Everything is being done and there is an urgency, patient is going to die and therefore you need this really fast. You can definitely go to court and ask for their interference. Otherwise, if there was a process, it could have been part of the law. It is not a part of the law. That is why you need to get the support from the court.
Just taking the discussion a little further, India is becoming a hub for medical tourism, and we see a lot of foreign nationals who are coming to India. And if you have a patient, foreign national organ disease, can he register in the country for organ recipient?
Yes, there are number of instances where foreign nationals have gone and bought organs. But now there is a hierarchy. The 2014 rules or the 2021 rules, I may be wrong in the year, clearly defines what would be the process. The process is Indian nationals first, then foreign nationals. So that's the hierarchy now. And usually now we have such a large disease burden. Of late, I have not seen any foreign national getting organ, because whichever organs get distributed on the noto side, we all usually come to know which organs have gone where. And if it's a foreign national, 5 years ago it would get highlighted, it's a foreign national. Now in the last 4-5 years, I haven't seen a foreign national receiving an organ. So, but foreign national can donate in India if they become brain dead. There are precedents of that, yes. You need an embassy permission. The embassy can give you permission and happen, and I think it will happen in one instance in Mumbai. The TCC managed to do that. I was not involved in the case, it was in some other hospital, but they did do that and the process went ahead. We had a young chap from, somebody mentioned about it, Dr. Shah only mentioned about it, from from his community, from Australia, a young 4-year-old boy whose story is very heart-wrenching. They had discussed about organ donation in his school in Australia. And he said to the parents that how wonderful this is. How luck would have it they were visiting India, the Indian origin people. He suffered irreversible brain damage and he was one of the youngest donors of Maharashtra at that time. And the community came out in quite a large support to actually help the donation. So foreign nationals can donate and the organs will be distributed as per the standard process. But foreign national to register for donation, the hierarchy is different.
Just extend this question. Sometimes there is a patient might be then dual citizenship, prospective recipient. If he has the dual citizenship, what are the current guidelines, legal implications that whether this person can be registered?
So the interesting part is dual citizenship in India is not permitted. So you will not have an Indian having dual citizenship. A person holding Indian citizenship will become a non-resident of India, a PIO, an OCI, all these other categories. But India does not have dual citizenship. So you won't have an Indian and an Australian or an Indian and a British, a person holding a British citizenship. So perhaps then it will boil down to the same hierarchy of registration for the purposes of registration. However, just to mention that with there was this issue that had come up before the courts regarding domicile. So domicile was struck down, and now with domicile being struck down, the legality may not be that you cannot donate, but the restrictions will be regulatory restrictions.
The waiting list pool and hierarchy, I think obviously for farmers it's most of the times. Because even if you don't have a recipient in our hospital, then it goes to the next other hospital in general pool within that area. If it is not next to the next state level, if it is region level, or it is not entire national level. So with the current disease burden,
it goes from one state to another, right?
It goes to all over India.
Go to Soto. From Soto, if there is no registered donor, go to Roto. From Roto, it then goes to a national Noto call. Roto call basically means that all the 5 Rotos get a call, including the Roto in which it was called. And then they will see if there is any potential donor. Trust me, Dr. Ghanshyam, there is always somebody. If we are not able to reach sometimes, there may be a donor in east, north, south, and the donation may be happening in the opposite end of the country. The patient's family may not have the resources to charter a flight and bring this. See, that's the problem. A lot of organs are not reaching the potential recipients because of the time constraints, because of the financial constraints, because of the way in which they can be transported as well. That's another problem.
I would like to mention one thing. It's interesting that we are discussing this, the hierarchy, etc. India is being promoted as a destination for medical tourism. I do believe that there may be some policies evolving around that, how the foreign nationals.
Yeah, I think that is happening right now. I mean, there are a lot of foreign nationals who come and get a transplant and heal. I mean, they get the relatives and they that happens. Yeah.
Sir, my question is, how a treating physician prompt the patient is brain dead in busy ICU? In a busy ICU, sir, what makes the treating physician to think that patient is brain dead?
So usually what happens, the first suspicion that the patient is brain dead comes up from the fact that the bedside nurse and the doctor, the registrar or the senior registrar, tells you that the pupils are not reacting. There is no trigger seen on the ventilator. The nurse will say that when I am suctioning, there is no cough, no gag. And then at the consultant level, we have to make a decision and see that was there a sedation going on, was there a muscle relaxation going on, Is the patient profoundly hypothermic? Is there any other confounding factor like electrolytes abnormality? All those things. So treating physician, in fact, will come to know very, very quickly. Within few hours of the absence of signs, these things are quickly notified because pupils are checked in any ventilated patient every hourly or 2 hourly by the bedside nurse. And if they are not found reacting, it's a big alarm bell. They will immediately inform that the pupils are not reacting, and then that sort of triggers the whole process.
I think the treating physician,
can such patient go unnoticed for a longer period in busy ICU like a setup in Indian setup? Such patients, those who are brain dead, can they go unnoticed for a few more hours?
So
before finding out the patient is brain dead.
So they may not go unnoticed, but there may not be a thought process that this is brain dead immediately. Every non-reacting pupil is not brain dead, right?
So can such patient go unnoticed for few hours, at least 24 hours, 12 hours?
Sir, if a person's pupils are not reacting and otherwise the patient was doing okay, and there is a diagnosis which could progress onto brain dead, you could still take up to 24 hours to decide whether the patient is brain dead or not.
Yes, sir. Then we decide by apnea test that we take the patient off the ventilator. Is it, sir? Is it right?
Yes.
That we take patient off the ventilator to decide the patient is brain dead or not with apnea test.
Correct.
So can the relatives of the patient turn table on us that patient has died 24 hours before or 12 hours before and the patient has been kept on ventilator for want of money? Am I right, sir?
That can happen even without the brain dead scenario. So that can actually, acquisitions can be anything, but if you have done, madam, I think you would be able to answer that question in a better way. Because if I have done everything right in treating this patient, I have nothing to fear about. Anybody can come and point one finger to me, that is going to happen regardless. But for that fear, I shouldn't stop doing what is right.
Can I add a small point? See, no matter how busy your ICU is, right, it is mandatory that you examine the patient very frequently. If you have not examined the patient, then yes, there is a possibility that forget about brain death. Even a cardiac death may be missed. If you are not examining, then yes, then you are not only liable by the patient, but I mean anybody can point a finger at you saying that you are not examining the patient. That is our primary responsibility as doctors, that irrespective of how busy your ICU is or how busy your hospital is, you are bound to examine the patient and interfere if there is a physiological deterioration. Suppose I have a patient, right, and I am not examining, my monitors are switched off, my doctor does not see, my nurse is not at the bedside, the patient had a cardiac arrest, nobody is bothered. I mean, there have been instances where patients have gone into rigor mortis and then the family comes and visits and then we all, people then realize, okay, fine, we have not seen the patient. Then yes, in that situation, we are liable. There is a duty as doctors that we cannot give an excuse that my ICU was busy or I was busy somewhere or my team was busy. If the patient is admitted under our care, then we are bound to examine him frequently depending upon his condition, monitor him and make sure that if there is any kind of physiological deterioration or deviation from his vital parameters normal range, we are supposed to intervene and act.
If I may just take a shot at that, and I think I'll be able to give you the legal answer. See, I remember some time back I'd done a case where I was arguing in the National Commission, the consumer, it was a consumer case. And it who had come into the hospital.
that, the child is very scared of doctors. A reasonable person with that professional qualification under the said circumstances. What the court said was that if the child comes in under a certain situation where the child is, running high temperature with a lot of pain, all symptoms are suggestive of appendicitis. Did you do all your tests as you should have done them? Was it a reasonable deduction that could have been arrived at? And did you do everything in the line of duty as you should have done to give the care that you are bound to give? And if you have done that, and that was only a secondary issue, the primary issue was something else, you don't become liable for that. I would give the similar analogy here. I would say if you did everything that you should have done under the circumstances as a reasonable doctor, not even prudent, reasonable doctor, then I think you are largely safe from any medical care. Right? If you did any negligence, then it is definitely something that will be a part of a litigation, and then you'll have to prove to court that you were not negligent.
But madam, in those two cases, patient presenting with pancreatitis and appendicitis, both are two different presentations, and any sensible doctor can diagnose whether the patient is presenting with pancreatitis or appendicitis. There is some gray areas there, but with the new diagnostic skills and with history and clinical examination, any sensible doctor can diagnose whether the patient has pancreatitis or patient has appendicitis.
This was 20 years back.
You were 20 years before. Madam, just a minute. Madam, I did my graduation 40 years before. I did my graduation in 1981 when we had only sonography, we had only X-rays. We had no sonography also. Sonography was introduced in 1983, madam. We had no sonography in 81, madam. During those days, 40 years before, we had no investigation apart from X-rays. No sonography, nothing, madam. Whatever we are seeing nowadays, we had nothing. We used to just with his examination, history, and clinical finding, and just basic investigation. Thank you, madam.
I think we will just close the session here. Just want to add one final point, right? What, and I'm sure most of you agree, as far as India is concerned, the law is very, very leniently, or I would say very much in favor of medical professionals. Right? So, yeah, please, one final question before we end the session.
In one of the lectures, I heard before giving methylprednisolone, we have to do cross-matching, sir. Is it mandatory and being followed regularly, sir? Because we never did it. In one of the presentations, I saw before giving methylprednisolone.
Dr. Arun has this one. See, he said yesterday, it's better to collect the blood sample before giving prednisolone for the donor. As it's it alters makes it difficult, actually matching difficult.
Is it mandatory, sir? We never
see when it is there is a chance to alter or modify the result. It's better always to follow.
One more thing about
see how much time does it take to collect the blood sample? Only 2 minutes. You can collect the sample and then move forward with it.
Transfusion triggers, we usually follow rule of more than 10 gram per deciliter. But in most of the things it is showed more than 7 is enough. Are we transfusing unnecessarily?
More than 7 is enough.
See, in intensive care, it's now a standard practice not to transfuse, transfusion.
See, if patient is holding, I think there is no need. I think up to 7 is okay. Above 7.
Completely sure, completely clear, madam. The transfusion trigger is 7. There is a rule of 10. There is a rule of 100, which I don't think a rule of 100 was discussed today. I will take this opportunity because you sort of said transfusion trigger. So The rule of 100 for maintaining a brainstem dead donor is try to keep the pressure, blood pressure of 100 systolic, heart rate around 100, urine output around 100 ml per hour, temperature as close to 100 in Fahrenheit, hemoglobin as close to 100 in millimoles per liter. Every 100 minutes check for sugar and sodium. Keep the saturation around 100%. You will never go wrong with the donor maintenance. So the rule of 100 is actually very easy. Just follow the rule of 100, except that transfusion trigger should be 7.
Thank you.
Thank you. Thank you so much for this insightful discussions. I'm sure that we were able to answer a lot of queries that we have. Thank you. I thank all the panelists. I thank my co-moderator, Dr. Amandeep, and hand over the mic to Dr. Sahiti to propose the vote of thanks. Thank you very much.
I request Shravanti ma'am, Center Head Medicover Hospitals, High Tech City, to hand over a token of appreciation to Dr. Amandeep ma'am. I request Malesh sir, Center Head, Chandanagar Medicover Hospitals, to hand over token of appreciation to Dr. Kishore Reddy sir. I would now like to thank Dr. Ghanshyam sir, our Director of Critical Care Medicine at Medicover Hospitals, who has been the driving force behind this initiative, from conceptualizing the event to curating the agenda and bringing together this incredible panel of experts. His leadership has been the backbone of today's success. I now invite Dr. Dilip sir and Shrikant sir to present a token of appreciation to sir. As we come to the end of today's insightful session, on behalf of Medicover Hospitals, I extend a heartfelt thanks to all our speakers and faculty for sharing your time, insights, and commitment towards advancing awareness on brain death and organ donation. A special mention to Ms. Purnima Kamli ma'am for her invaluable session on the legal and ethical dimensions of organ donation. To all our delegates and participants, thank you for your active engagement and thoughtful questions. A sincere gratitude to the organizing team for your meticulous planning and to the marketing and communications team for ensuring the message reached far and wide. Lastly, thank you all for your presence, passion and support in promoting this life-saving cause. Let us continue to carry this mission forward, giving life beyond life. Thank you.